will speak about her life experience and how simulation can fit into social justice. Dr. Bajaj will attack the issues, thinking about the linkage between simulation and data to drive our goals. And Dr. Jen Arnold will speak to her experiences and where experiential learning has an opportunity to create impact. We have an incredible day ahead of us where I hope we will get a chance to explore these topics and think about where we fit into the fight toward health equity as educators, providers, mentors, and people. This is being for the first time broadcast to the world through YouTube stream. We want you to interact in this conversation. We'll be monitoring the YouTube chat. Put your questions and thoughts there to share in the conversation. If you want to contribute to the chat, you'll need to have a YouTube account with your email. There will be a panel at the end of the day with some of our speakers to address some of your questions. And if you need to step away from the stream, this will be recorded so you can come back later. There will be a break halfway through for you to grab a bite to eat, stretch for 10 minutes. And as there's no exact roadmap, I hope today inspires you to pick up a pen and start drawing a way forward with us to guide how we are using education as a tool to create real outcomes in health equity. So without further delay, I'd like to welcome Dr. Michelle Allen. She's the Senior Vice President and the Chief Medical Officer at New York City Health and Hospitals. She's also an alumna of our system, having graduated her OBGYN residency from Jacobi Medical Center and works clinically at Bellevue Hospital. She's been a guiding light for our health system through her support and programs addressing disparity, equity, and inclusion issues, and has always advocated for simulation to be at the forefront of moving the needle and creating change for the system. So without further ado, Dr. Allen.
Good morning, everyone. Can you hear me? Great, Mike. Good to see you this morning. Nothing like a challenge starting in your first role leading this conference, but you are the person for it. Welcome, everybody, to the 5th annual Symposium on Simulation. And, you know, with our children, we love all of our children, but each one is special. And the Sim Lab and the Sim program actually has a very special place in my heart. We started using simulation in obstetrics after we had a series of catastrophic shoulder dystocias. And it was eye-opening to see and participate in that simulation. It really emphasized teamwork. Everyone has a role. We went as a team, the attendings, the nurses, the PCAs, the house staff. Who was the runner? Who took the vital signs? Who led the debriefing? Who did the delivery? It was a real lesson. In obstetrics, we have catastrophic events that we don't get to actually, thank God we don't get to see them often enough. They're very rare, and when they occur, they are catastrophic. We started with the shoulder dystocias, and looking back and looking at the number of settlements, med mal cases that we had secondary to shoulder dystocia, we actually saw a decline in litigations based on our training. And we went from there to the obstetric hemorrhage. We all know that's a leading cause of death for pregnant women and leading maternal mortality metric. We also from there went to CPR in labor. Again, something, thank God, we don't do frequently, but due to the training and simulation, we've had several women whose lives we actually saved because of the OB stat training. With Ebola, it was the simulation, secret shopper, that helped us improve our ability to greet patients who were recently traveled with diarrhea and fever, identify them, and give them the proper care. In early COVID as well, the secret shoppers and the Sim Lab helped us prepare and identify patients when we didn't know it was COVID, when we thought we were seeing people with devastating pneumonia. How do we handle that? Went on to the trauma teams using the cut suits where they actually practice what they need to do in the OR with their traumatic injuries. Training our house staff, central line insertion. And with the emphasis on diversity, inclusion, and equity, and again, from the obstetric lens, where we really try to identify substance use disorder in pregnancy early. How do we screen women for substance use disorder without being biased, When we looked at our own internal data, there is actually evidence of bias in who were we screening and who were we testing. So our latest endeavor, with the support of Dr. Magadushian, we're looking at making sure that our providers, when they do the universal screening and approach toxicology testing, that they don't bring their own biases, a bias about appearance, a bias about color, a bias about hairstyle. And I want to thank Mike for taking this on. I want to thank Mike for making this the emphasis of this symposium today, equity. I'm looking forward to hearing our speakers with their tremendous background and education, and look forward to learning some more. So this is a very exciting day. Um, I do also want to take a moment to recognize the individuals. Lindsay Beach, the PA, for her work in simulating education with the surgical ICU PAs. Carissa Schneider for her work with residency training. The behind the scenes quiet heroes, our communications department, who helps us to get our word out. Whenever I write something, I can depend on them to edit it for me, so it's in proper English and grammar. The Coney Island Respiratory Care team for their outstanding commitment throughout the COVID-19 pandemic. The maternal mortality program, the active shooter program, the Metropolitan Satellite Center, Coney Island Hospital, Kohler Hospital. I want to thank you all, and look forward to a wonderful day. And let's get started, Mike. Let's get going.
Great. Thank you so much, Dr. Allen. I'm going to go ahead and pull down the slideshow real quickly. Okay. So when we talk about using simulation as a tool to bring about change with diversity, equity, and inclusion, our maternal mortality reduction program serves as a shining star example of things that can be done. It's been for the last 4 years that our team has been working tirelessly executing in-situ simulation experiences. Keeping my intro short because I want the team to share what they have been doing to invite conversation about implicit bias within the care we provide and how it can impact health outcomes. So with that being said, I'd like to invite Lauren, Marlene, and Kimberly to the front.
Thank you, Michael, for that wonderful introduction. Good morning, everyone. My name is Kimberly Campbell Taylor, and I'm the Director of Nursing Simulation here at New York City Health and Hospitals. I would like to take this opportunity to extend a warm welcome to everyone that is present today. My team and I will be presenting Maternal Mortality Reduction Program Simulation, Diversity, Equity, Inclusion in Action. For the next 10 minutes, we will be discussing the nuts and bolts of our program. We will also cover some of the topics, how we incorporate diversity, equity, and inclusion into our program. We will review some metrics and some data. And at the end of our presentation, we will have a brief video of our team in action. Before I move on, I want to say that our team has no financial disclosures. So let's begin. The Maternal Mortality Reduction Program is a City Hall initiative that was developed in 2018 due to call to action as the critical maternal mortality data in the United States and New York City came to a head. This data highlighted the disparities between Black, brown, and marginalized birthing patients in comparison to their white counterparts. Our program utilizes a multi-pronged approach. which includes simulation education and training, maternal homes that provide pre and post pregnancy care, and enhancements in our electronic medical records across the system. I know you want to know who does this lovely work. We have an amazing team. We have 2 nurse educators, 2 coordinating managers. We also have obstetrical consultants, OB-SIM core teams across our system, and that helps to create an agile team approach to help meet the unique needs of all 11 of our acute care facilities. This is done via in situ simulation, which is work that happens in the actual work environments. It is also done via the 6 OB mini labs that were built and completed in 2021. And it also includes simulation skill training that gets coordinated in both of those work areas. Our program is over encompassing, and we actually covered a number of topics that we rolled through our current calendar. Those topics include OBACLS, which is unresponsive mom, postpartum hemorrhage, and shoulder dystocia. On the horizon for our team includes hypertensive disorders in pregnancy, thromboembolic disorders in pregnancy, and virtual reality, which is due to roll out in 2022. I would now like to take the opportunity to pass the baton to one of our wonderful nurse educators on our team, Marlene Harford.
Thank you, Kimberly, and good morning to everyone. So, recent statistics released from the New York City Department of Health for the period of 2016 to 2018 shows that there has been an overall improvement in maternal mortality with the multi-pronged approach to addressing this issue. What is troubling, however, is that the disparities remain unchanged. Black women are still 5 times more likely to die from complications surrounding childbirth than white, non-Hispanic women. What is even more alarming is that in 46% of all pregnancy-related deaths, discrimination was identified as a probable or definite circumstance surrounding these deaths. The report also indicates that most of these deaths were preventable. So we acknowledge that we all have implicit bias, and we are striving to recognize these biases and mitigate them to improve patient outcome. We appreciate the need to shift from recognition that we all have implicit bias to transformation with the goal of changing discriminatory behaviors and policies to achieve better outcomes for Black birthing people. To this end, our simulation-based education now illustrates diversity within simulation technology with the use of Black mannequins for our scenarios. SimMom, as shown here, is our first generation high-tech, high-fidelity mannequin. We also use this brown prompt with a simulated patient for scenarios such as postpartum hemorrhage and shoulder dystocia to meet our learning objectives and to provide opportunities for our multidisciplinary teams to practice together with an implicit bias lens. As simulation educators, we ensure that every simulated scenario is reviewed for underlying implicit bias and includes learning objectives that address racism and other related biases. Our debriefers are prepared to discuss the role of implicit bias in all our courses. The hope is that this commitment to address institutional or structural racism and other related biases that negatively affect patient care be understood and be an expected professional responsibility. Psychological safety is crucial for these conversations, and so we pay particular attention to the establishment of a safe container during the debrief and pre-brief in which learners can really take advantage of a safe, brave space to speak up, to make mistakes, and to fully engage in the simulation and debriefing to have these difficult but meaningful conversations. So now, with great pleasure, I would like to invite Lauren Williams, our coordinating manager on the MMRP team, to kind of share with you how we measure what we treasure. Lauren?
Thank you so much, Marlene. I would like to take a moment to discuss how we measure and report data. Before the start of every simulation, data is collected in real time via QR code to capture staff participation via SurveyMonkey. All participation data is then uploaded onto Excel workbooks, utilized for extrapolation, for reporting to various stakeholders, including people like City Hall, as well as the New York City Department of Health. The current slide is an example of how we measure staff participation by discipline in OB-ACLS, postpartum hemorrhage, and shoulder dystocia simulations. In the past several years, we have trained over 2,500 staff members, including attendants, residents, anesthesiologists, RNs, midwives, and CRNAs. The next slide is an example of our postpartum hemorrhage metric checklist, used to measure obstetric simulation activity and outcomes performed during each postpartum simulation. Some of the metrics observed includes timing of postpartum hemorrhage diagnoses, timing of medications given, timing of attendant arrival, and other pertinent tasks performed during a postpartum hemorrhage code. Moving forward, we are looking at translational data. We want to centralize measurable outcomes in relation to the SIMS performed by the Maternal Mortality Reduction Program and obstetric clinical outcomes. This approach will give us an opportunity to evaluate the longitudinal impacts of the program for years to come. Now I would like to introduce a short 3-minute video of News 12's reporting of our simulation activities. It was conducted at Bellevue Hospital in an effort to combat disparities in maternal outcomes and tackle implicit bias. Due to some technical difficulties, there is a possibility the volume may not be heard. If so, please try to enjoy the video. There is a lot of activity that you can visually look at. On behalf of the Maternal Mortality Reduction team, I would like to say thank you for your time and enjoy the video.
Well, across the city, many advocates have rallied for birthing justice, fighting maternal mortality, especially for Black and brown women.
And News 12's Aisha McKenzie is taking us into a simulation lab within the NYC Health and Hospital system that's meant to not just treat life-threatening childbirth situations, but structural racism in medical spaces.
Now, we want to note for you what you're about to see is a simulation, but it may seem graphic to some.
This is how the labor and delivery team at New York City
And according to reports from the city's health department, and the Bronx seeing the worst outcomes.
We learned that, you have to pay attention to the patients and advocate for the patient.
And after each sim, the team debriefs.
Grow, share, and learn. We want to have all of us have a shared mental model and hear all the concern.
The simulations are run by the Maternal Mortality Reduction Program team of 4, going to each hospital for trainings, and according to them and others involved, care is improving.
We're really trying to dig into the metrics, and with our electronic medical record, we're really trying to show the bang for our buck in a way, because we really want to go ahead and shout from the top of the rooftops, like, practicing is what's going to make the difference, and we're going to actually try to impact care.
The training that we offer is really going to be a game changer for New York City. It's going to continue a major culture shift.
A culture shift that many have been fighting for. Aisha McKenzie, News 12.
So can I stop the share? And no, I don't want to pull up anything.
Oh, so you can clear if you want to clear.
Oh, clear.
If you're done. Yeah.
Okay. Thank you, MMRP team. This video was enlightening. My name is Tatiana Malvoisin. My pronouns is she and her. I am a simulation specialist at NYC Health and Hospital Simulation Center. I am also the co-chair of the Simulation Safety Council and the co-chair of the Diversity and Inclusion and Equity for the Simulation Center. Today, it's an honor for me to have the opportunity to introduce Dr. Michelle Morse. Dr. Michelle Morse is the inaugural Chief Medical Officer and Deputy Commissioner of the Center of Health Equity and Community Wellness at the NYC Department of Health and Mental Hygiene. Dr. Michelle's agency works in bringing public health and healthcare to reduce inequality and serve as a key liaison to clinicians and clinical leaders across New York City. In 2019, she was the first Black woman to receive the George W. Thorne Award, which was established in 1975, and is the highest clinical education honor by the Brigham and Women's Hospital Department of Health. She also launched a global campaign against racism as a Soul Equity Fellow. Dr. Michelle Morse is an internal medical physician at Kings County Hospital in Brooklyn. She earned a bachelor's degree in science of science in French in 2003 from the University of Virginia, a medical doctor from the University of Pennsylvania School of Medicine in 2008, and a master in public health from the Harvard School of Public Health in May 2012. Please join me in welcoming Dr. Michelle Morse.
Hi there. Thank you so much. I hope you all can hear me okay. Thank you for the generous introduction. And it's a real honor to get to be with you virtually. I've been looking forward to this conversation, and I hope that we'll have a little bit of time for Q&A. I do have a few slides prepared that are really looking at what justice looks like in the COVID era for medicine and public health. And I'm going to speak a little bit about anti-racism work within our public health work. And of course, I'm really interested and open to some conversation as well. I'm going to speak briefly because I know we're running just a little bit behind on time. And again, hope that there'll be a few minutes at the end for discussion. So with that, I'll jump right in. Can you all see the slides? You can. Okay, great. So you can move to the next slide. So I'm going to speak a little bit about critical race theory. I'm also going to speak a little bit about race explicit strategies or race conscious strategies, and then also a little bit about anti-racism work. And a lot of this conversation is going to be about how we can build critical consciousness. And critical consciousness is a term that Paulo Freire and many others developed as a way to really describe how we can both grow our understanding of critical issues, social, structural, and otherwise, and do so collectively. And note that critical consciousness really is, it's essentially an analytic tool and skill that I think it's important to have for all clinicians and providers and everyone who's taking care of patients. Next slide. I always like to start with this just basic framework around what the drivers of health are. And this really describes social medicine in a nutshell. Social medicine is, an approach or framework around medicine and public health that really sees health as something that is socially, structurally, and politically driven. And that's what you see on this slide. Certainly as providers, many of us who are nurses or doctors are trained mostly in the biological and behavioral circles on this figure, but it's truly the social and structural drivers that I think are critically important for us to both expand our consciousness around and really engage in changing. Next slide. In addition to that, I think it's important for us to remember that even though we have profound inequities within the United States, sometimes we forget that we are relatively wealthy and are certainly one of the countries that unfortunately participates in global geopolitics that leads to extraction of wealth and resources from the global south. And this map from Globe Mapper is just one visual representation of how the global north, you can see here the United States, Europe, and Japan, much, much larger on the map than their usual size because they have a disproportionately large amount of wealth compared to the continent of Africa, for example, on this map, which again shows the ongoing impact of colonialism and how wealth inequity globally is also a critical driver of global health inequities. Next slide. And to come back to the United States, even if we look at our country compared to other rich countries in this world, we are an outlier in the United States. And this is really unfortunate. If you look on the x-axis, it's looking at income inequality. And if you look on the y-axis, it's the index of health and social problems, which is an index that includes things like life expectancy, infant mortality, social mobility, amongst other metrics. And there's a linear relationship between income inequality and the index of health and social problems, as you see on the slide, with the United States being a huge outlier with some of the highest income inequality and some of the highest ranking for the index of health and social problems. Clearly, there's a relationship between these two things. Next slide. So with that context in mind, let's just talk a little bit about critical race theory and how we as health workers and providers need to continue to raise our consciousness and awareness about how critical race theory can actually be helpful in understanding medicine, public health, and racial health inequities. Next slide. So some of the tenets of critical race theory are listed here. Unfortunately, critical race theory has gotten a lot of negative attention from right-wing media news outlets as they truly seek to redefine what critical race theory is to serve their political agenda, unfortunately. And that is really an erasure of history, and it's also just dishonest. But that's another reason why I have included this slide about critical race theory. I think it's really important for us as health workers to engage with it as a part of how we build critical consciousness. It is an incredibly informative theory in helping us to understand the situation we live in the United States with the persistence of profound racial health inequities. Despite, as many of you know, this is the 20-year anniversary of the publication of the Institute of Medicine, which is now called the National Academy of Medicine, report, Unequal Treatment, that described in detail the extensive nature of racial health inequities across this country. And yet, 20 years later, 70 years after the civil rights movement and 20 years after the publication of that report, we still have some of the most profound racial inequities in the world. In fact, when you look at, and I loved the presentation of the birth equity group just before me, again, we constantly cite the fact that Black birthing people are 9.4 times more likely to die than white birthing people in this city of New York, right? To have such a profound inequity like that, we need to be able to understand that. And critical race theory helps us to do that. So some of the tenets, and I should also mention, critical race theory comes out of legal studies. It is a critical theory that was developed in the 70s, 80s, and 90s as a response to the backpedaling and backsliding that the United States experienced after the civil rights movement, where many of the winds of the civil rights era were eroded over the decades following the 1960s. And these legal scholars wanted to develop a theoretical framework that helped to understand and explain why that was happening right before their eyes. Derek Bell is one of the founders of critical race theory. He was actually the first ever Black law professor at Harvard Law School. He actually took a leave of absence because by the 1990s, Harvard Law School had still not had a single Black woman of color on their faculty. So this is someone who truly believes in understanding how racism shapes opportunity and how to fix it. So Derek Bell, again, a very important figure in this work. But we as providers and clinicians have to understand, again, as I was saying on that first slide, how important the social sciences are for us to build our critical consciousness. So there's a lot for us to learn from the legal colleagues that we have, including this tenet of critical race theory, that racism is thoroughly embedded in society, and that race is a social construct, right? It is not biological. So the fact that there's a 9 times increased rate of death for Black birthing people is not about any biological differences between Blacks and whites. It is truly about the way our society prioritizes human beings and who counts and who doesn't. So critical race theory helps us to understand that race is socially and politically constructed, not biological. So any differences we see are truly a result of marginalization, oppression, and the way our society has chosen to prioritize resources. And then there are many other tenets, but I just want to underline intersectionality. Many of you are probably familiar with this tenet of critical race theory because of Kimberly Crenshaw's groundbreaking work establishing this tenet. And it's truly about the fact that people who have multiple marginalized identities, so for example, if you identified as trans and Latinx, and you were not making a living wage, for example, those would be multiple marginalized identities in which that individual in a society like ours would have a different kind of magnitude of experience of racism, as opposed to someone who doesn't have multiple marginalized identities. So it's about these interlocking systems of oppression and how the impact of having multiple marginalized identities, unfortunately, is often greater than the sum of the parts and requires unique societal action in order to address it. Next slide. The other important thing I want to underline is how critical race theory can be applied to public health. And a mentor and friend, Chandra Ford, and her colleague Collins Ironbua created public health critical race praxis as a way of applying critical race theory to public health. And they say that science is not objective, again, because racism is thoroughly embedded in society, and that it's important if we want to end racial inequities that we generate knowledge outside of our core knowledge base in medicine and public health, because unfortunately, racism has shaped the very research questions that we're even asking in a way that we are not conscious enough about. And again, because this talk is both about a just future for medicine and public health, but also about how we as health professionals have a responsibility to raise our critical consciousness and awareness about these issues, this is the kind of work that I hope all of us can continue to delve more deeply into, so that we start asking even better research questions and do even better programmatic interventions that are race conscious, rather than ones that excuse me, may exacerbate racial inequities if we don't consider and look at the racial equity impact of the programs that we're doing. Next slide. So one example of this is therapeutics for COVID. On the right is a graph from the CDC of national data on who is getting treated with monoclonal antibodies by race and ethnicity. And what you see here is that people of color and Hispanics are specifically much less likely to get monoclonal antibody treatment, despite having a disproportionately high rate of COVID impact and unfortunately negative COVID outcomes. What the New York State Health Department attempted to do in this realm on the left-hand side is actually tell providers, listen, you know, race, non-white race and Hispanic ethnicity are risk markers for poor COVID outcomes, unfortunately, because of the longstanding history of inequities and racism. And therefore, because of that, because of the disproportionate impact on people of color and Hispanics, that means that we should actually prioritize them for treatment. And you can consider race and ethnicity in that way, because that is what equity looks like. It's resources according to need. And unfortunately, we often struggle with operationalizing that concept, even when COVID has shown such a terrible light on how profound the racial inequities are in our society. Next slide. So let's talk briefly about two examples of race explicit strategies. Next slide. I want to briefly mention some of the work we've done on heart failure at Brigham and Women's Hospital. And this is work that I did before coming to the health department. What we looked at was 10 years of data, almost 2,000 unique patients admitted to the hospital with heart failure. And the hypothesis that we had was that white patients were more likely to go to the cardiology service, and Black and Hispanic patients were more likely to go to the general medicine service. What we also knew was that readmission rates for cardiology patients were lower, and that rates of cardiology follow-up were also higher in patients that were on the cardiology service. Next slide. So we published the analysis looking at where patients were triaged to when they came in with heart failure. And we corrected for and didn't actually find an association with insurance status, with comorbidities based on the Alex-Salzer comorbidity score, and with multiple other potential confounders. And what we found was that Black patients and Latinx patients only went to the cardiology service about half of the time, whereas white patients went to the cardiology service about 2/3 of the time. Now, if you use Kamara Jones's definition of racism, racism is a system of structuring opportunity and assigning value based on how one looks, which is what we call race, that systematically advantages white people, disadvantages people of color, and saps the strength of the whole society. Well, then this is an example of institutional racism, because white people have more access to this resource, which the resource being the cardiology specialty service. Now, that's not fair. And so our data analysis proved that this pattern of institutional racism was happening at our hospital when it came to heart failure care, and we decided we needed to do something about it. Next slide. And sorry, I just described this. You can move to the next slide. I also just described this. Since we're running short on time, I'm just going to move forward to the next slide. And what we also did was we published about not just how important it was for us to do this analysis, but also how the Black Lives Matter movement created a window of opportunity for institutional change at our hospital. In fact, the summer of 2016 that many of you probably remember, when Alton Sterling and Philando Castile were murdered by police, that created a significant movement amongst trainees and house staff at the hospital. And they were pushing for more prioritization, visibility, and investments in health equity work. And that is actually the infrastructure that was built that allowed for this study looking at our heart failure inequities. Next slide. But what was important for us also was to be able to understand the mechanism by which this was happening. And so we did a survey of providers in the emergency department to understand the drivers of their decisions. And what we found, even though the study was cut short because COVID started just a few months after we initiated this survey, what we found was that the providers in the emergency room told us that white patients were more likely to advocate for themselves to go to the cardiology service, and that advocacy influenced the decision of the provider in the emergency department about what service the patient was going to go to. So we see this as an example of how white privilege gets operationalized and can drive racial inequities and institutional racism. Next slide. And for some reason, I guess this is out of order. You can move to the next slide. You can move to the next slide. So let's just briefly talk about global vaccine inequities as a reminder again about what I described or what I showed on that globe mapper map at the very beginning of the presentation, where I, again showed how wealth and colonialism are important drivers of inequities. And here in this article, we were able to publish a description of just how important it is for us to move forward with global vaccine equity. And the reason I mention this again is because I think consciousness amongst us as health providers about the interdependence of this world, certainly the Delta wave, as well as the Omicron wave, showed us that unless everyone has access to the vaccine, all of us are going to, unfortunately, not be able to make as much progress in health equity as we would like. And so what we also know is that about 80% of people in wealthy countries are vaccinated, only about 10% of people in low-income countries are vaccinated. And this is despite the fact that since the fall of 2020, countries in the global south, including South Africa and India, have been pushing for intellectual property waivers to ensure that they could actually manufacture these vaccines themselves and get them out to the populations that they serve. And to this day, those intellectual property waivers have not been implemented. And so again, just a really important reminder to us to remember how interconnected we are and how much not only colonialism, but again, structural racism shapes who gets access to things like vaccines. Next slide. I just want to also remind us of the trends, and this gets back to what I described in critical race theory. This gets back to why the Black-white inequities in multiple different areas continue to be problematic in this country, again, since the civil rights movement. If you look at unemployment rates, if you look at the rates of people who've completed four-year college, if you look at median household income, home ownership, incarceration rates, and then even life expectancy at the bottom right, the gap between Black and white has not closed in 7 decades. And we have to be able to explain that. In fact, it's gotten worse for home ownership. And even though I don't have it listed here, the life expectancy inequity between Blacks and whites in this country has also gotten worse. Just in 2020, Black people in this country lost an average of 2.7 years in life expectancy because of COVID, whereas whites lost an average of about 1 year. And so again, these inequities are persistent, and actually some of them are worsening. So again, critical race theory helps us to understand why that might be the case. Next slide. But we have to figure out how we end these inequities. So one of the solutions is reparations. And Dr. Bassett, who's now our state health commissioner, has published about this, and the fact that the racial wealth gap is one of the key drivers of inequitable health outcomes. In fact, it's also clear, and this is a study done by the Federal Reserve Bank in Boston, that wealth is actually probably more influential than income. And income is often how we stratify health data, but stratifying that data by wealth is assets minus debt. Wealth is assets minus debt would be an even more powerful way to look at the relationship between wealth and health by race. The Federal Reserve Bank of Boston looked at this and saw that on average, white households in Boston had $247,000 in wealth, and Black households had an average of $8. And so again, those inequities could be solved in part by reparations, but certainly also we need additional race-conscious interventions to end the racial inequities that we see across this country. Next slide. So one of the things that we did to try to solve the heart failure inequities that I mentioned earlier at Brigham, was we developed a framework called the Healing Arc. And the Healing Arc is a series of 3 steps. It's acknowledging the wrong that has been done and the racial inequity that exists. The second step is redress. These are programs and policies that seek to offer restitution for the injustice that has happened. And then closure, which is focused on the community that has been impacted negatively, really getting to determine when healing and restitution have been completed. And this builds on the work of our colleagues Sandy Darity and Kirsten Mullen, who are economists and who have written extensively over the past 30 years about reparations and reparative justice. So this is what we're doing at Brigham and Women's Hospital right now, is we're implementing the Healing Arc as an approach to end the racial inequities in heart failure that we uncovered. Next slide. Unfortunately, there's been a tremendous backlash against this work. In fact, again, the right-wing media has attacked our work and unfortunately lied and offered a lot of misinformation about what we were actually attempting to do. And this has been really unfortunate to see. And at the same time, we have been able to continue to push this work forward and continue to have the support of Brigham and Women's Hospital to be able to make this possible. Next slide. I also want to highlight just how important it is for us to learn together as providers and health professionals. It is really, really important that as we continue to find solutions to end racial and other health inequities, that we center communities. In fact, that is a tenet of critical race theory. It's centering the margins, which you've probably heard lots of different times. Centering the margins is very much about using a framework that builds on the experiences, priorities, and assets of the communities we serve in order to address health inequities. And this includes a theory of change that's built on understanding inequities in resources and power and decision-making, and actually repairing those inequities as a way to move forward with ending all the different kinds of health inequities that we see. Next slide. Finally, I just want to highlight some of the policy work that has happened around anti-racism, and I think it gets at this idea of race-conscious strategies that I've described. If you look at the Board of Health resolution that was passed in October of 2021, it's only 3 pages long. And I hope that you'll take a look at it and read some of the statements. But what it does, it both describes the context in which racism is operating in the United States, and also the Board of Health requires us at the health department to do a series of actions that will help to end racism, or interrupt cycles of racism in New York City. Next slide. So this is my final slide, I believe. I just want to read a few of the statements as a final consciousness raising and hopefully provocative series of statements before we open it up for comments and questions. As I mentioned, it's only a 3-page long resolution. I hope you'll read it in full. These are just a few of the statements from it. whereas settler colonialism, indigenous genocide, and enslavement of Africans are part of the history of our nation, and whereas these original injustices have been without comprehensive restitution or redress, and whereas racism is a race-explicit system and anti-racism requires race-explicit strategies, and whereas the work of undoing racism is grounded in love as well as science and civic duty, this love is not sentimental. Rather, it's what James Baldwin called the tough and universal sense of quest and daring and growth. So with that, I'll turn it back over to you, moderator, for any questions or comments.
Thank you so much, Dr. Morris. Really appreciate your comments, and so interesting, and hopefully this will lay a good foundation for us to think about where we have a lot of work to do, and hopefully where we have the opportunity to go ahead and work toward tackling inequity and fighting using some of the tools that we have. Next up, I have the privilege of introducing our next speaker, who is the Chief Learning Officer and Interim Chief of Diversity and Inclusion here at New York City Health and Hospitals. Over her 20-plus years at Health and Hospitals, Ms. Mendez has worked across our system from Woodhull to Cumberland Diagnostic and Treatment to Central Office. Under her leadership, the system has received global recognition with multiple awards, including Training Apex Top 100 Training Organizations and Brandon Hall Excellence in Learning Award. She has been working with the Diversity and Inclusion Office to integrate unconscious bias, religious awareness, employee listening, and LGBTQ awareness trainings. We thank you for all that you have accomplished, Ms. Mendez, for our city, and we're excited to hear how Health and Hospitals is integrating diversity, equity, and inclusion into our workforce today. So if you don't mind sharing your screen.
Good morning, and thank you so much. As the Systems Chief Learning Officer and Interim CDIO, I'm very happy to support and participate in today's 5th Annual Simulation Symposium. As you know, the theme this year is promoting equitable health outcomes. Therefore, I'm going to spend the next couple of minutes speaking to you about our strategy regarding diversity and inclusion when it comes to training throughout H&H. Incorporating strategies on diversity and inclusion is one of the most important roles of a learning and development professional. When you attend any type of training experience, you want to walk away, or you want your learners to walk away, not only with new learning, but also with a feeling of being connected, a feeling of being represented in the training that you receive. That connection can be established in a multitude of ways, and it begins at the very beginning where you're starting to design the elements of your training. As you know, at New York City Health and Hospitals, we have a very diverse workforce population. And so we have to ensure that when we deliver training, those trainings, we have to make sure people see themselves in the training, whether it's individuals that have the same ethnicity, that look like them, that have the same beliefs. And you also have to embed that into the simulations, the case studies, and the manner in which the training is developed and the content that is going to be absorbed by the learner. Therefore, when you develop training, keep in mind, you want to create a learning environment where our learners feel involved, where they feel respected, valued, connected. In other words, what you want them to do is you want the learner to bring their authentic self and feel that they are in a safe environment. What that's going to do is that's going to bring another level of depth to the training that you provide. When an individual comes to your training and they feel that they're in that space where they can share their best self, you're not only going to have that individual learning from the training, but you're going to have that individual sharing. And what that's going to do is that's going to start embedding diversity and inclusion into the facet of everything that we do. Because not only will the learners learn from the actual modalities that are being taught, but they'll learn the differences in their beliefs, the differences in their thought processes from one area to the other. This being said, our learning strategy at New York City Health and Hospitals is multifaceted. The first level of our training strategy is really to create a sense of awareness amongst all levels of staff on all different types of areas that fall within diversity and inclusion. So if you visit the Learning Academy site and you click on the Diversity and Inclusion tab, you're actually going to see trainings, whether they're live trainings, whether they're e-learnings, and they're focused on achieving health equity, providing culturally responsive services, diversity and inclusion in healthcare setting, health literacy, and so much more. And so what we want you to do as a workforce is really start becoming acquainted with terminology, start being acquainted with best practices, start being comfortable with the uncomfortable. And so that's a first level. But diversity and inclusion does not just live in training. Diversity and inclusion does not live just in the diversity office. Diversity and inclusion lives within you. And so what we have to do is that when we're developing trainings, not only the training that's focused on diversity and inclusion topics, but any type of training we deliver to the system, any type of training, you have to start thinking about how are we representing those modalities that are being taught? How are we embedding different thought processes? Maybe, regardless of whether it's somebody from LGBTQ, whether it's a male, female, whether it's ethnicity, how you look, how you feel, you want your training to be representative of all cultures. Because then and only then will you begin to use that venue in terms of having diversity and inclusion not just become a topic or a subject that we teach, but actually become a process in the way that we do our business, we conduct ourselves with each other, and we conduct ourselves with our patient population. So I know I'm limited on time on this one, and I can speak to you all morning on this, but I'll wrap up with this. Once again, D&I is everyone's responsibility. As learning professionals, as diversity and inclusion practitioners, learning is a very important vehicle in ensuring that we continue to evolve and transform the culture at New York City Health and Hospitals to one of true inclusivity and belonging for all. Thank you so much and enjoy the rest of your symposium.
Thank you very much for the presentation. Good morning, everyone. My name is Alex Lee. I'm a simulation specialist here at New York City Health and Hospital Simulation Center. It's my privilege to introduce our next speaker, Dana George Trottier. Dana's preferred pronouns are he and they. He is a licensed creative arts therapist, a registered drama therapist, and a board-certified trainer. He holds a master's degree in drama therapy from New York University, a certificate of advanced training in LGBTQ healthcare, and graduated as a fellow in healthcare simulation from NYC Health and Hospitals Simulation Center. Dana is currently a clinical supervisor for behavioral health sciences, providing clinical and administrative supervision to a multimodal team of creative arts therapists and mental health providers across the spectrum of psychiatric care. They serve as adjunct faculty at the New York University and Antioch University, Seattle, as well as visiting faculty at the Institute for Medical Simulation and Advanced Learning at NYC Health and Hospitals Simulation Center. Currently, they are pursuing a PhD in counselor education and supervision at Antioch University, Seattle. He is also active in co-editing books and involved in numerous research projects as well. Now, I am delighted to announce that Dana will be joining New York City Health and Hospitals Simulation Center full-time as the Director of Fellowship Program. Welcome, Dana, and take it away.
Thank you, Alex, so much for that wonderful introduction. I'm going to go ahead and share my PowerPoint with you all. So thank you again, Alex, and I'm really excited to be here with all of you as I share with you a little bit about cultural responsibility and using simulated patient methodology to move cultural competence into responsive action in behavioral health. I'm coming to you all from the Bronx, New York, and I'd like to acknowledge that this presentation is taking place on the traditional territory of the Lenape homeland and recognize the longstanding significance of the presence of the Lenape people on these lands. I believe the historical awareness of exclusion and erasure is critically important, and I'm committed to overcoming their effects in our healthcare system. In the next 20 minutes or so, I aim to raise awareness about cultural responsibility, invite us to consider how to build these skills within healthcare, and some considerations for using simulated patients to achieve this outcome. With this, I recognize that we could spend a full day just talking about this topic, so consider this a taste of things to come. I want to start with this quote that's often attributed to Viktor Frankl and popularized by Stephen Covey. Between stimulus and response, there is a space. And in that space is our power to choose our response. And in our response lies our growth and our freedom. In our practice of self-awareness, which is a key component to responsive care, I ask that you check in with your own body process during this presentation and consider the space between the stimulus, the content of this presentation, and your response, the actions you take in relationship to the content. And invite yourself to monitor this awareness or mindfulness over the course of the day and across the different presentations you hear. As it's in this space that we find the opportunity to liberate ourselves from some of our automatic thoughts, our biases, and we consider shifting the singular narrative that we hold of others to an appreciation for the multiplicity of narrative. And interestingly enough, mental health could be defined as the ability to be aware of this gap between stimulus and response, and the capacity to use this gap adaptively. It's crucial to name and acknowledge the history of behavioral healthcare and the historical trauma it has caused marginalized communities. We continue to see the effects of these historical narratives present themselves in modern day practice. While perhaps not as overt, the covert nature of injustice maintains its grips in the training and practice of behavioral healthcare. And the target, unfortunately, becomes our clients. And so we can trace this back centuries, right, where we begin to see the pathologizing of women as hysterical, the pathologizing of protesters during the civil rights movement, the pathologizing of sexual orientation and gender identity, and the ongoing bills and laws that are being passed day by day that are impacting access to healthcare for LGBTQ folks. And although I'm talking about history, I think the reality is that our history is here in the present. As we consider the fact that Black patients are almost twice as likely as their white counterparts to be diagnosed with schizophrenia and prescribed higher doses of antipsychotics. And that 1 in 8, which I imagine is a bit underrepresented, LGBTQ plus people have experienced unequal treatment from healthcare staff, and 1 in 7 avoided treatment altogether. And as we begin to experience multiple marginalized identities, for example, being queer and a person of color, that those numbers double. And what we see within behavioral healthcare in itself is that 53 to 81%, depending on the intersections of their racial and ethnic minorities, report experiencing 1 or more microaggressions during psychotherapy. And that 53% of clients experience at least 1 racial microaggression, and that 76% of those participants reported that it was never addressed in the session. And only 50% of counselors on average are able to identify 1 of 3 microaggressions when shown a video recording of a counseling session that intentionally incorporates microaggression actions. And so what becomes the outcome? Early termination, low treatment utilization, minimization of symptoms, negative treatment outcomes, feelings of anger, shame and being misunderstood, and a weak therapeutic alliance. And the research shows us that therapeutic alliance within behavioral health care accounts for 70% of successful outcomes. And so what we begin to see is that marginalized folks often delay or decline to seek mental health services out of fear of being discriminated against. and that research suggests that microaggressions and cultural ruptures occur regularly in care, and these ruptures often go undetected and unaddressed. So what do we do? First, we breathe. We breathe and we consider that space that exists between stimulus and response. Take a breath as we continue to think about what to do next. Which leads me to a consideration that the power of cultural ruptures and their invisibility to perpetrators and targets alike, without awareness, their occurrence in psychotherapy, and insight into their impacts, these ruptures transpire in a manner that undermines the therapeutic relationship and safety and trust between the client and the therapist or the clinician. And given the urgency here, I ask, how do we as simulationists and educators create brave spaces where our learners can practice necessary skills to increase their capacities to take action in their practice? How do we bridge the gap between stimulus and response with intentionality? I'm going to show you a series of dyads. And as I show them to you, I ask that you take a moment and consider the identities and roles you begin to take into your awareness. Feel free to write them down if that's useful, or just hold them in your mind. And ask yourself the question, what do each of these individuals bring into relationship with each other? And you may notice that some of the things that are rising up to you are assumptions or biases, and that these are understood through your contextual lens, through your own socialization. And notice how your body shifts as you're appreciating your experiencing. And really take in these dyads and begin to think about the relationships that are at play. Now, being that I'm a drama therapist, I'm going to shift the dramatic tension a little bit and go ahead and introduce some quadrants to you for consideration. So as we add the labels, a privileged client, privileged clinician, marginalized client, marginalized clinician, how does the narrative change? In what ways do you see the power shift? And perhaps in what ways were your initial assumptions inaccurate? Or maybe they were spot on. But these are the things we want to begin to consider as we're thinking about building cultural responsibility. So I've used the phrase cultural responsibility a number of times, and it feels important to ground that for us. That Dr. Nisha Sajnani highlights that responsibility, with its double allusion to a learned skill and an ethic of accountability, is a cornerstone to our care practices. That responsibility is the ability to be mindful of ourselves and the thoughts and feelings that we're experiencing as a result of an internal and external stimuli. Again, the stimulus and our response, and the space that exists in between. It involves a groundedness and a centeredness, a mindfulness, if you will, and the ability to consciously and deliberately choose our response with intention and care. So cultural responsibility, if we add the cultural flavor to it, combines two ideas: cultural competency and cultural humility. When you think of cultural competency, I imagine what comes to mind is a checklist of things that we can do as healthcare providers to be able to mark off that we're culturally competent. This fails us if it doesn't move us into action, and it doesn't drive health outcomes. Whereas cultural humility is a lifelong learning process, a process-oriented approach to competency that supports the ability to maintain a relational stance that is other-oriented with respect of cultural identity that is important to that person. So here I am asking us to begin to create a relationship between culture and responsibility, marrying cultural competence with cultural humility. And it becomes our cultural responsibility to our clients and colleagues to embrace and embody these competencies in practice. So when we consider the domains of cultural responsibility, I want to invite us to consider these four domains that exist. That we have our attitudes and beliefs, which are commitment to practice counseling and advocacy from a multicultural framework. That we have our knowledge, which is the understanding of relevant theories to guide that competent practice. and our skills, which is interventions informed by multicultural and social justice informed attitudes, beliefs, and knowledge. And then there's a fourth one, action, which is where I believe simulation and simulated patient methodology comes into play. This is the embodiment of attitudes, knowledge, and skills to drive responsive choice making. In other words, it's taking our attitudes and beliefs, our knowledge and skills, and moving them into practice, almost as if we're operationalizing them and allowing them to become part of our everyday practice as we begin to bridge the gap between stimuli and the opportunity that it may provide us in helping to reinforce cultural responsibility. I think some important reminders is that simulated patients are trained to portray clients for instruction, acquisition, and assessment of clinical skills. That they're trained to maintain consistent, highly realistic portrayal. In other words, they're trained to help maintain the fiction contract, to suspend that disbelief, to allow for it to feel as if the stakes are as they would be in the clinic. And that they're trained to give feedback to trainees on their skills, especially from the role of client, which is a really unique opportunity in training to get to hear the client's perspective. And that they're prepared to tailor the encounter to meet the needs of diverse learners and introduce variation of human characteristics to achieve learning objectives. In other words, they're prepared to be spontaneous and to adapt to meet the needs of the learner to drive towards the learning objective. So if our learning objective, for example, is to build cultural responsibility, and we're working on navigating our attitudes, our knowledge, and our skills, that the simulated patient themselves may assess their learner to be more in the attitudes kind of phase of that domain and will adapt their performance to be able to help that individual begin to move from one domain to the other. So then the question becomes, what are some topics or skills that are related to cultural responsibility that can be explored through simulated client methodology and behavioral health? Well, I certainly have a number of ideas that I'm really excited to think about, like using simulated patient training in culturally responsive assessment and diagnosing, recognizing that the history of assessments within behavioral health have historically been applied and designed for and by white clinicians, and thinking about the ways in which these tools are adapted, or perhaps even creating new tools for individuals who don't exist within that privileged identity. How can it be utilized using simulated patient methodology to train clinicians in family therapy and being able to introduce the family, which is a large aspect of the cultural context, to be able to navigate some of these conversations? Or practicing dialogues with clients around their salient aspects of their cultural identity, or interviewing LGBTQ plus folks if, for example, some of the languaging around that community is new to you. Being able to have an opportunity to try it out in a psychologically safe space like a simulation gives you the opportunity to try it out without judgment. And empathy training to develop a deeper appreciation for client experiences. So how can we begin to maybe even use some of the tools that we in their own empathic capacity and the lived experience of the other? Again, working towards bridging that gap between and so how can we begin to name and locate microaggressions and those that come up for me when I consider the next steps with using simulation and behavioral health care? And I thought I would just leave us with some considerations. One consideration I want us to hold in mind is that cultural identity should never be considered noise in a simulation, but rather signal towards consideration of the cultural context of the patient. That it's important to remember that the humanity of the other is not noise, but that in fact could really give you a different and a deeper appreciation for the mental health challenge that the individual is experiencing if you can begin to locate it within their cultural context. And that rehearsing broaching difference with simulated patients move attitudes, knowledge, and skills into responsive action by intentionally bridging that gap between stimulus and response. And that if we can begin to diversify our simulated patient pool to provide opportunity to learners to meet a variety of humanities. And what's wonderful about the moving into virtual spaces is that we consider a simulated patient program that has a global perspective. How can we connect with folks across the globe to begin to understand that the folks that we provide care to, especially here at health and hospitals, is one that is diverse and one that comes from a global perspective. And that we need to begin to incorporate questions about equity and just care into debriefing that focus on bringing the dynamic lifeways of the learner and the simulated patient to the forefront. And with this, a recognition as the simulated patient as part of that process. Questions to consider integrating into your debriefings. How might your own positionality be contributing to the way in which you're viewing their care? How might your client's intersectional identities be contributing to the way in which you are conceptualizing their care? And what systems of oppression may be at play in this therapeutic encounter? And of course, how does your client understand their struggle within their own cultural context? As health literacy is one of the main components of moving towards equitable care, how can we begin to help our clients to understand their illness within their own language and their own cultural context so that they understand perhaps the impact that it's having on their quality of life or their ability to be successful in community? And that we need to center the knowledge and uplift the SP role as a patient teacher who is lending their body and aspects of their life narrative. And it's crucial, this is crucial in countering the dominant narrative in healthcare. So recognizing that simulated patients are not just another tool within simulation, but in fact are humans who can bring aspects of their humanity into the simulation, which will ultimately just create a deeper learning process for us all. It's my hope that in this short time that I have created a stimulating enough environment that's eliciting you a large space to explore as you consider your responses to the next steps. And that as you think about moving your practice in health equity a bit further, that you hold on to your own cultural context and to begin to understand the lens through which you're viewing your own training development programs, and really give yourself the space and grace to ask questions and to get curious with your colleagues who maybe have diverse backgrounds, to integrate some of their perspectives into your training so that it is a well-rounded global perspective that we're bringing into our healthcare simulations. And with that, I thank you all so much for the time. And of course, if there are any questions and comments, feel free to pop them in the chat, as I'm sure we can find some time at some point to address them. Thank you all so much, and enjoy the rest of your symposium day.
Thank you for that presentation, Dana. Moving on to my apologies. Thank you for that presentation, Dana. Moving on to our next presenter. Good morning. My name is John Cruz. I'm manager for the New York City Health and Hospital Simulation Center. It is my honor and privilege to introduce our next speaker, Dr. Desiree A. Diaz. Dr. Diaz is an internationally recognized scholar, researcher, and associate professor at the University of Central Florida College of Nursing. She has been a nurse educator for the past 16 years and was one of the first 20 people in the world to be a certified healthcare simulation educator advanced. Dr. Diaz completed a simulation research postdoc with Dr. Pamela Jeffries at Johns Hopkins University related to empathy and caring. Her research interests have included improving human health, which combines the cutting-edge technology of simulation with the deeper human emotion of empathy to improve the care of underserved patient populations. Dr. Diaz has both developed and built simulation programs in diverse settings, such as in correctional health, where she created the world's first prison simulation van. She has directed multiple campus simulation programs, including collaborating with community partners. Dr. Diaz is a fellow in the American Academy of Nursing and the Academy of Nursing Education. She is a recent family nurse practitioner graduate and is an ANCC board certified medical surgical nurse. Dr. Diaz exemplifies the terms innovative, interactive, creative, and flexible. Let's welcome Dr. Diaz.
Well, thank you so much. I am very honored and happy to be here. I first want to start by asking a question. I'm not sure if you all have any audio feedback, but the last couple speakers, actually, I had some feedback. So just let me know and we'll be able to work through that, I hope. As we start, I want to first start by saying this is a safe environment for us to have this conversation, because my goal today is for us really to push that envelope of our thought processes, as well as a critical reflection of where we're at. So when I'm starting to speak today and talking about other, and what does other mean, and how does that create dissonance, I think we need to feel safe to share. So my goal is that you will log into the chat. Not quite sure, being totally transparent, how that's going to work with me. I think it'll pop up on the screen, so I'll try to be responsive. I am okay with silence, and I will move forward and past that. So as we start to talk about identified as other, the creation of dissonance, I have some disclosures. The opinions that I'm going to present today are mine, Desiree Diaz's. It is not the University of Central Florida or Florida, for that matter. I do not give permission for anyone to utilize any of the pictures in this presentation, and that'll be forthcoming. You'll see why momentarily. All the pictures presented are meant for discussion points, and I won't stay on them long, but it's just really a launching pad for us. As we continue through our talk, a couple of things. It's a safe space to delve into the idea of dissonance. And it's also a time to have a conversation related to the insight of our role as healthcare providers within that simulation space. So let's get started. What do you know and do you think of when you hear the word dissonance? Is it really discord for you? How does that sound? Is it a negative word for you? So let me hear your thoughts. So some of the words, it means conflict, discord, a discrepancy. Now, anyone? Thoughts? I've put the Webster's Dictionary definition up there for you, so you can cheat and look and see what that is. But dissonance means the lack of agreement. I often say that I like healthcare discrepancies as a word rather than healthcare disparities, because a disparity implies something that might be nebulous. It is a fact. Whether a discrepancy requires active participation and initiation to change that. It is an active role for social policy advocates or social justice advocates, right? So when you think about the last time you went to a store or a restaurant, if there was a discrepancy in your bill, what do? You call the waiter over, you note what that discrepancy is, and then a solution happens. A change takes place. It is active. It is not just a disparity. Well, you charged me $100. I really thought it was $60. Okay, here's the 100. I'm never going back there. I'm going to write a poor review. A discrepancy means we're going to have some conflict resolution. So before we move forward, I need to know, what is your operational definition of dissonance or conflict in relation to healthcare disparities, related to the disconnect that we have currently, we'll say, in our simulation society? Anyone want to delve in on that? Okay. So we will move on, and as we start, let's start and look at the beginning. So if you look at the beginning of this, this is actually my birth certificate. So hence, no, you do not have permission to copy or share my birth certificate. If you look at the top of this birth certificate, you will notice, besides the fact that I was a little chunka at 8 pounds, 11 ounces, I was labeled as other at birth. My father's descriptors are West Indian, other for race, and it only discuss his job as a scientific lab tech at Pfizer. On my mother's side of the birth certificate, which this is a United States birth certificate, it states Guyanese, she's, born in Guyana in South America, race as other. So in the very beginning, before I even had a true identity of self, somebody else declared I was other. Now, when we start thinking about, well, how does that continue on? How does that perpetuate? When we were listening earlier to one of your speakers, 7 decades of nothing being changed. So you can quickly say, oh yeah, that was 7 decades ago, so 70 years. What's happening today? Well, let me tell you. How does it perpetuate? So this is roughly 20 years later. This is my marriage certificate. In my marriage certificate, highlighted or blacked out is our social security numbers. That was actually on the marriage certificate. My husband is labeled as Latino as a race, identified as Puerto Rican. I now am labeled as Black as a race, and then it lists my parents' lineage. So again, now I have dissonance, right? Discord. There's a conflict from what my legal birth paper states to another legal government document. So, okay, so that's 20 years difference. And there's a change. So instead of other, now I'm Black. But now I go to have my first child. My first child, and this one's a little bit more blurry, but it's a launching pad, a discussion. I am labeled as Black, other. My husband's labeled as Puerto Rican, Hispanic. So this is on now our child's birth certificate. So when we talk about things that perpetuate, if we don't correct dissonance or discord, it continues. But if there was a discrepancy, could we change that? We should be able to change that, correct? Now, I would like to acknowledge, just as a little break, that my parents did allow this zygote to mature from conception to being an other. I'd also like for us to think about this as a fluid discussion. I know you're a little silent right now, because the past is prologue. If we don't look at our past of how we advance, then we're stuck there. So as we continue, this is where I want to spend our remaining 20 minutes or so. How does labeling affect the current state of healthcare simulation? So let's start with that, and I'll leave this slide up so you can continue to refer back to that. How does labeling affect the current state of healthcare simulation? Here's a way that labeling affects the current state of healthcare simulation. When we say we have a 34-year-old Black male in the ER with high blood pressure, does that identifier of Black pertain to the simulation case? Now, there's a lot of difference of opinion on that within the simulation community and the simulation environment, right? We can't negate what someone's ethnic or racial background has an effect on their healthcare, but is it relevant to the simulation case? And why do we have to have separate pockets? No, everybody's race has to be in the case. Does it need to be in the case? Or do we just want it to be in the case? If we choose to have the descriptor in the case, are we choosing to have the deeper conversation about the healthcare disparities, about social determinants of health within that? Now, please put in the chat, are you using race and ethnicity as a descriptor? So I'll give you a little minute to type in, and please write, what is the first race and ethnicity that comes to mind? And if you are you addressing how that affects outside of the simulation, outside of that one-stop scenario? For instance, if you have a case and you have a Afro-Caribbean Hispanic female, such as one of the scenarios that I've created, are you taking the time to discuss high risk factors for maternal child infant mortality related to Black and brown women dying at a higher rate than non-Hispanic white women? If your answer to my question is no, why do you have that in there? Just so you can check a box for DEI? And is that really doing that justice? Are you having a missed opportunity to create social policy and justice advocates? Because action is the power. So what's your thoughts? Anyone have thoughts? Okay. If we don't label in some other situations within simulation, are we missing opportunities to discuss specialized care? Are we missing the ability to bring in cultural congruence within our simulation scenarios? An example of this would be, you have a 65-year-old, no, let's go a little older, an 80-year-old Hispanic female comes into your ER, brought in by the grandson. Let's not even talk about language access. So fully fluent in English per our standards of fluency in the ER. Now you should be asking, well, why did she say per our standards of fluency in the ER? Well, what happens in the ER? Who's deciding if someone needs a medical interpreter? It's typically the triage person who may not be a medical person. It's the intake person who the first thing we do is get insurance cards, right? Identification. They're deciding if this person needs an interpreter or not. Are they trained to make that evaluation? So that is a whole other conversation we can have. So when we are looking at that scenario, we have an elderly Hispanic woman who is now obese, BMI of 38, 40. She is in there because she was complaining of, let's say, diabetic symptoms, whatever spectrum we want to be, either high or low. Let's go with high. Are we understanding that cultural congruence is understanding where she is at in that time, in that moment? Do we understand the culture of her Hispanic heritage that has brought her to that point? Or do we have bias related to obesity, sizeisms, not just ageisms, but sizeisms? Are we allowing the learners in a simulation to work through that? To understand and bring in that cultural awareness piece of what is the average diet consists of in that Hispanic household. When we don't label, we can miss opportunities. But I hope you're understanding the point. It should be deliberate with deliberate time focused on the health standards of best practice and taking that time in the debrief to have that discussion. There's more to simulation than doing a skill, right? We can teach anyone a skill, but do we allow learners to process their personal bias, their personal belief? How does that merge with scientific data with the patient in front of you? Or are we only concerned about the skill at hand? So as we move on, how can we create diverse environments without dissonance as we begin to discuss discord? So that gets a little bit deeper. What are your thoughts with that? Can you create these diverse environments? Now, we talk about, or I will bring my own scenarios into play. That way I'm not projecting anything on all of you. So we have a scenario with the LGBTQ plus population, and we have a trans male in the scenario who presents to the emergency room with signs and symptoms of anxiety. So he also complains of a headache, and he's chest binding and doing these things. Now you say, well, okay, what's the problem, Diaz? What's the dissonance? What's the discord? Many of our learners have never experienced caring for a trans individual. That aspect is important in that case because we deliberately take time to talk about the high anxiety, depression, and suicide rate in that population to hopefully mitigate some of those ill responses, to provide services for all of our patient population. But you have to allow people the space and the opportunity to talk about their personal discord, their personal clash of what they may think, believe, feel, or have been taught with what the patient is presenting at hand. Have you created any diverse environments that realistically created on purpose this discord? Dr. Baja wrote something in the chat. I really can't tell if I'm seeing your questions or not, or your answers. So please let me know. Have you created scenarios that you wished you had some time to create the discord within that environment? Now, we'll talk about it, I guess, when we can unmute the mics at the end. So I'll go to my last question for us. Should we be considering the similarities rather than the differences we possess? Should we start looking at how are all of us connected rather than how all of us are different? Would that create better understanding when there's a link? Oh, I understand. Thank you for that. So there's a lag in the time on YouTube. Can we think about, when I think about my West Indian culture, I used to think we're the only one, that everything's surrounded by food, laughter, family. We're happy, we eat. We're sad, we eat. If it's a wedding, we eat. A funeral, we eat. If someone's in the hospital, we're all there, lots of visitors. Until I really started to explore some of the other families I was seeing. Very similar to an Italian family. When I'm in the hospital setting, everybody's there, especially if it's Nona in the bed, it's the grandma. Same types of things. So instead of looking at the difference, can we look at those similarities and create a cultural congruence? Now, cultural congruence, is a term that really is looking at the process of effective interaction between the provider and the client and where they interact. But that takes deliberate practice and deliberate effort to be able to do that. Are we providing learners the ability to practice that so then that they can transform that into the clinical setting. In the hospital setting, are we able even to do that? So that's where I want us to launch off our discussion. I was thinking that we would be able to share some of our ideas of how can we propel and push things forward within the simulation environment to create culturally congruent providers in the workforce. Also social advocacy within that workforce setting, because simulation is the starting point, the launching point of providing a safe space to learn, interact, and then have concerted action and purposeful action. So let's have a discussion. Okay.
Hi, Dr. Diaz. So there's been some comments within the chat on YouTube saying that, you know, some of our providers work within pediatrics and they're wondering how they can go ahead and use this as a way to make a difference, or does it make a big difference when it's a pediatric population? We've also had some comments saying that because a lot of our particular patients are Black and Hispanic, that we have been going ahead and focusing on those populations to actively discuss implicit bias. There are disparities and discrepancies, and that needs to be acknowledged because marginalized persons tend not to be able to navigate either because of the historical and modern day impact. And that people are including race and have very deep conversations around culture in order to have shared decision making to better understand what's going on with their culture. So these are some of the comments that have been coming through the chat.
Well, let's tackle the pediatric question first here as we go on. Understanding the culture in which that child or that minor operates in is really important because they may be experiencing two worlds. I know I did growing up. I grew up in a very strict West Indian home, and then you go out into the world and see all these other things. Wait a minute, how come I am not experiencing the same thing my counterpart in that classroom is? It's the same type of thing in the hospital setting. So will that child function or thrive or heal in that same environment if we don't address the cultural concerns? And that is something that we have to have, that family-centered care, that connection between both. But I will tell you what I experience on the educator side is our young providers, whether it be residents, nurse interns, on that younger, say 28 and younger level, they don't know how to mitigate that. They may not be parents themselves to understand that influence or that disconnect. So providing the conversations with the child included creates a shared model amongst the family as well as that pediatric patient. I think related to simulation itself, it's truly having the ability, can you provide an embedded participant to be the mom who might be questioning every single move, or the dad or the grandma within that scenario where your learner can practice respectful communication. Now, respectful communication is very different amongst many cultures. So it's providing those opportunities to practice before integration.
Can I also ask maybe your opinion on
You went blank. I couldn't hear you. My opinion on.
Can you hear me
Have
now?
lots of
There we go.
opinion. Yes.
Yeah. In terms of going as an educator and thinking about how to go ahead and design lesson objectives and things, how are you going ahead and informing your lesson objectives with that cultural lens? Say we wanted to go ahead and, like for me, for example, I wanted to create a whole simulation around West African culture, but I obviously didn't grow up in that household. How do we go ahead and create that with that lens to be able to address some of those cultural implications and impacts on healthcare?
I think community partnerships is vital in any of these. You're not going to find one person that is the cultural representation of an entire race or ethnicity. You can go to community centers, community partners, and it's creating that relationship. And it also creates a symbiotic relationship where they understand you are trying to provide the best care for their people within that context of whatever your healthcare is, your healthcare practices are. So I believe that it requires us to really think about our community partners who can address some of those nuances within the general culture. And I also believe it's vitally important to state that we understand you are not the sole representative of every West Indian in the United States. Desiree Diaz's experience is very different than Patrick Richardson's experience, who happens to be my brother, but it's very different. Girl child versus male child, very different in our culture. So it's having that understanding, and it's all comes down to intent. Is your intent to foster care, communication, or create more of a barrier? And when people really see the desire of your heart, they're very willing to help and understand. So vet those scenarios.
I love that idea of being able to vet the scenarios themselves. I think that's very smart. I was wondering, have you ever partnered with standardized patients or outsourced standardized patients for the purposes of being able to attack cultural competency, or are there services like that that exist?
So I think that's a really tricky question. So thank you, I guess, for that question. So there are services, but for me, my greatest example is partnering with the Social Justice and Policy Group and the Lavender Council on campus. So it is a cadre of LGBTQ plus people that came in. We had a partnership. I trained them to be standardized patients so they could represent their specific gender expression within a scenario, because they felt like they wanted to have a play in how we are educating future healthcare providers. So I think that's important. It all comes down again to where do you recruit? You can go to the Asian Cultural Center and have a variety of Asian cultures that you can recruit from to enhance your SPs in that pool, with the understanding I'm going to train and educate you on how to be an SP, and you're going to just be yourself within the cultural context in which you're trying to project into that scenario.
I love that. And actually to be able to speak from how they felt or how it impacted them during the care experience, during the simulation, I think it really is an incredible voice to have. Really grateful and thank you for some of these ideas. So we will be having you later on in our panel discussion. So I'm hoping that people will stew on some of these thoughts and ideas and be able to go ahead and bring up some questions. But I really love the notion of thinking about how we are targeting cultural competency by going ahead and being targeted with our learning objectives when we go ahead and create our simulations and really focusing on how we create our educational experiences, and really be open to other people having influence on how we're doing that, because we can't know everything. So thank you so much.
Thank you.
And more from Dr. Diaz a little bit later. Now we're going to present the annual Simulation Symposium Awards, where we get to celebrate the contributions of the health and hospital simulation community for those who are in attendance. What we're going to do is we're going to be talking about you, and then you'll have come up and get your award. And then we also want to acknowledge some people a bit later who are not here, and we'll go ahead and share a PowerPoint presentation with them for the purposes of being able to share our excitement around them. So if I could actually get a little help to share the presentation.
Thank you very much, Michael. Thanks also for the opportunity to present these wonderful awards to these lovely, well-deserving people. So as we call your names, you can please join us. And Lauren, you can also join me. So the first award is for outstanding contribution to New York City Health and Hospitals OB in situ simulation program by an individual. We are proud to offer this award to Ms. Shirley Guevara. Shirley, coming up. So Ms. Guevara is the simulation core team leader at Queens. She is a fierce advocate for multidisciplinary participation in simulation and therefore leads by example. Ms. Guevara is always present for every simulation, coming in early and staying late when she needs to. She shows great pride in her team, and she feeds back to us experiences where staff indicated that simulations better equip them to handle some of the OB emergencies that they face. She follows up on latent safety threats and makes system improvements and policy changes as needed. She rallies the multidisciplinary team and gets creative in her methods of doing so when the process gets challenging. She performs no-go assessments timely and informs us of cancellations early so we can offer support to other sites. We are truly happy to recognize and honor her efforts. Well done, Shirley. We love you. You're welcome. Okay. The second award is for outstanding contribution to New York City Health and Hospitals OB simulation program by another individual, and we are proud to offer this award to Ms. Gerlin Dubé Whittingham. Ms. Dubé has been and continues to be very instrumental in simulation education for maternal child health at Elmhurst. She constantly shares knowledge and updates in healthcare practice. As a 2021 fellowship graduate, she utilizes creativity in experiential learning and debriefing to constantly move the needle towards improvement. Her influence fosters an inclusive culture of safety in the birthing unit. During the obstetrical hemorrhage rollout, she facilitated simulation events by conducting 2 simulations on each shift in one unique MMRP visit, creating several opportunities to capture an increased number of participants. She also worked diligently to achieve 100% saturation for OB nursing staff at Elmhurst. Thank you, Gerlin, for your partnership, passion, and perseverance. We admire your strength and courage. Thank you. And we want to give a shout out to her mentor, Kimberly Campbell Taylor, who supported Elmhurst for the past 3 years. The next award is for outstanding contribution to New York City Health and Hospitals simulation program by an individual. And we are happy to offer that award to Lindsay Beach. Lindsay, come on up. Oh, great. So Lindsay, Chief Physician Assistant for Jacobi Surgical ICU, has embarked on an intensive effort to bring simulation education to the surgical ICU physician assistant at Jacobi. Her initial occasional simulation days for physician assistants have morphed into monthly educational offerings that encompass a mix of both hands-on skill practice as well as attendance in established simulation courses. Lindsay is currently in the process of building a formalized monthly educational program for physician assistants that will span the full academic year. Take a bow, Lindsay. Keep up the good work. The next award is for outstanding contribution to New York City Health and Hospitals Simulation Program, Inaugural Simulation Week Excellence. And this award goes to Kula Rehabilitation and Nursing Care Center. Do we have a representative? No. Okay, during their first year participating, oh, they're just walking in. Great, come on up. Happy to have you. So during the first year participating in Healthcare Simulation Week 2021, Kula, under the direction of John Boyne, created a patient transfer video from a bed to a wheelchair using a Hoyer lift. They were creative in using simulation as a means to practice the transfer. The video also emphasized the mission and values of New York City Health and Hospital, focusing on eye care, integrity, compassion, accountability, respect, and excellence. Thank you for participating in Simulation Week, and we are so excited to support the growth of your simulation at Kula. Congratulations, we appreciate you. Thank you. Okay, the next award is for outstanding contribution to New York City Health and Hospital OB In Situ Simulation Program by a healthcare team. And this award goes to Lincoln Core Team. Come on up, guys. So Lincoln has a consistent, robust team of nursing and physician leadership who work diligently and tirelessly to plan, organize, and execute OB simulations. The team members are Dr. Ruchi, core team leader, Joanne Desiree, Associate Director of Nursing, Monica Anderson, Assistant Director of Nursing, Sandra Kam, Satellite Sim Center nurse, Adrian Dozier, nurse educator, Dr. Lauren Toner, attendant physician, Charmaine Smith, head nurse, and Dr. Carmen Sultana, chief of OBGYN. These team members are very passionate about the value of simulations. They are all active members of the team and are always present for the simulations. They find ways to make it fun and exciting for all the participants. They learn and rotate facilitator roles, and they give and receive feedback graciously. This allows them to grow as a team, resulting in the team being able to deliver high-quality simulations independent of MMRP. With the entire OB leadership ever present and leading the way, Lincoln staff is always engaged and fully immersed in the sim experiences. We are humbled by their commitment. Team Lincoln, we salute you. Thank you. Okay, the next award is for outstanding contribution to New York City Health and Hospitals simulation program by a department. And this award goes to Coney Island's Respiratory Care Department. Coney Island's Respiratory Care Department, led by Laura Gazzara, managed a tremendous increase in patient cases during the COVID-19 pandemic. Despite the increase in patient volume, Laura managed to keep the team's morale up, even when the team members became sick themselves. She also supported simulation education during this time. She partnered with simulation educators from the Sim Center to train internal medicine staff in basic ventilator operations using a newly purchased ventilator-compatible mannequin. Laura ultimately sponsored one of her staff members, Leho George, to complete the simulation fellowship this year. Her commitment to simulation education, especially when that education was most needed, is commendable. Well done, Laura. You're really an asset to your department. We appreciate you.
All right, next up is Outstanding Simulation Program Award by Department. Central Office's Communications and Marketing has worked tirelessly to promote the Simulation Center since its inception in 2010. From a feature article and video clip in New York Times about the use of simulation to aid the reopening of the labor and delivery unit in North Central Bronx Hospital, to the promotion of the maternal mortality reduction program, which was attended by Deputy Mayor Hermenia Palacio, to the publication of our events, such as Simulation in Healthcare Week and today's Simulation Symposium. Communications and Marketing has worked throughout the years to highlight all of the work the Simulation Center is doing. The Simulation Center is grateful to Communications and Marketing for helping to share all of the amazing knowledge gained today by allowing the Simulation Center to stream this symposium on Health and Hospitals YouTube channel. Thank you so much. Is anybody here to represent? No, okay. Up next, we have Outstanding Contribution to New York City Health and Hospitals Simulation Program. Simulation Week Excellence over 5 years, Coney Island. Coney Island has proudly participated in Healthcare Simulation Week for the past 5 years. Every year, Coney Island has gone above and beyond with its creativity to organize and execute a successful Simulation Week event. Last year, in the midst of COVID, the simulation team at Coney Island created a TikTok video to showcase one of their simulation encounters. Thank you for sharing simulation excellence with your staff and community. Thank you, Coney. Next up is Outstanding Contribution to New York City Health and Hospital Simulation Program by a healthcare team, Active Shooter Program. Janice Holleran leads the Active Shooter Program out of Jacobi Medical Center. Her team has been offering the Active Shooter course for many years. Learners practice their response to a situation no provider ever wants to be in, no provider ever wants to be in to protect themselves and their patients. Recently, Jacobi suffered its first real active shooter situation, creating a huge demand for more courses. The team did not miss a beat and stepped up to offer multiple classes, meeting the demand. They have created a model program that sets a precedent for the entire system. Thank you so much for your contribution. Next award goes to Outstanding Simulation by an individual. Natalia Sanayas, Chief Nursing Executive, has created a new Director of Nursing Simulation role. She's responsible for incorporating simulation into nursing education. We look forward to the ongoing learning potential that this collaboration will unleash. Thank you, Natalia. She's not here. Accepting the award on her behalf. Okay. Next up, we have Outstanding Contribution to New York City Health and Hospital Simulation Program by Satellite Center, Sterny Seligson. Sterny Seligson is an emergency medicine physician's assistant who oversees simulation education at New York City Health and Hospitals Metropolitan. After graduating from her fellowship, Sterny, with the support of her hospital, drafted a first business plan for a simulation center at Metropolitan. Without brick and mortar space to create a program, she has worked with Dr. Roger Chirugi to create simulation opportunities around the hospital and identify latent threats, improve code team training, and execute simulation with the highest quality. We look forward to seeing the Metropolitan Satellite grow in the up and coming years. Thank you so much, Sterny. And last but not least, we have outstanding contribution to New York City Health and Hospitals simulation program by an individual. Carissa Schneider is a pediatric emergency medicine attending who oversees simulation education for not one, but two distinct departments at Jacobi Medical Center. After establishing a quarterly simulation-based pediatric emergency medicine grand rounds for the Pediatric Emergency Medicine Fellows, Dr. Schneider then began monthly simulation days for the pediatric residents at Jacobi. Dr. Schneider also oversees 2-week simulation rotations at the Simulation Center for her pediatric emergency medicine fellows, where the fellows not only gain firsthand experience on the ins and outs of delivering simulation education, but they also get an opportunity to write and test a simulation scenario that is then used on their colleagues during the next grand round session. Thank you, Dr. Schneider. I would just like to say on behalf of MCEL, thank you so much for your time, dedication, and efforts. Thank you all.
So we just heard that Anna Maringo is here to accept her award. Please come on up.
Yeah, say it again.
Is that central office?
Yeah.
Oh, that's central office. Okay.
There you go.
Hi, Anna. Please come on up. I'm going to go back. All right. Yes. So this is the award for outstanding contribution to New York City Health and Hospital Simulation Program by a department. Central Office's communication and marketing has worked tirelessly to promote the Simulation Center since its inception in 2010. From a feature article and video clip in New York Times about the use of simulation to aid in the reopening of the labor and delivery unit at NCB, North Central Bronx Hospital, to the promotion of the Maternal Mortality Reduction Program, which was attended by Deputy Mayor Hermania Palacio, to the publication for our events such as Simulation and Healthcare Week, and today's Simulation Symposium. Communications and marketing has worked throughout the years to highlight all of the work the Simulation Center is doing. The Simulation Center is grateful to communications and marketing for helping to share all of the amazing knowledge gained today by allowing the Simulation Center to stream this symposium on the Health and Hospitals YouTube channel. So thank you so much for your efforts. Thank you so much for your contribution. We really appreciate you. Thank you, thank you. Picture. Yes, indeed. We appreciate you. Thank you.
Thank you so much for this recognition.
Thank you so much, everybody. So what we're going to do is we're going to move into a break right now, just so that people can go ahead and get some refreshments and get up, go pee, do all those things. For the people who are receiving awards, we have a photographer here from Jacobi, and so we're hoping that we might be able to capture some pictures with you guys, and kind of share in this event and be able to get some really good candids of you. So if you don't mind sticking around, there is some food actually over on the other side. We'll be reconvening at 12:35.
Can you hear me?
Yes, is that Dr. Davis?
Yes. Hi.
We
Great.
hear you.
Okay. I couldn't hear you. I was worried. Good
Yeah, we just have our
morning.
mics off.
Okay, great. I was just doing a check. Okay, perfect.
Dr. Davis, you have share capabilities, right?
Yes. Would you like me to start sharing now?
No, 12:30. Oh, it is 12:35. Michael, are you ready?
Sure, and I'd like to introduce Dr. Davis. So welcome back from our short break, and hopefully some of you guys have some food and had a little opportunity to stretch your legs as we are looking to continue our program. Very excited to welcome you back, and it's my pleasure to introduce our next speaker, Dr. Nicola Davis. Dr. Davis is Vice President and Chief Population Health Officer at New York City Health and Hospitals, overseeing innovative care models, population health analytics, chronic disease prevention and management, and the social determinants of health. Dr. Davis also co-chairs the Equity and Access Council at New York City Health and Hospitals. She received her Bachelor of Science from Sophie Davis School of Biomedical Education, her medical degree from New York University School of Medicine, and completed her residency training in primary care, internal medicine at Montefiore Medical Center. She obtained a Master of Science in Clinical Research Methods at Albert Einstein College of Medicine in 2003. Dr. Davis is board certified in internal medicine and obesity medicine. Her research and clinical work has focused on addressing obesity among low-income African American and Latino communities, particularly among those with diabetes. Dr. Davis was recently recognized as a 2022 Notable Black Leader by Cranes New York. She has also served on the board of the Council on Black Health and is an associate editor for the New England Journal of Medicine Catalyst. Please join me in welcoming Dr. Nicola Davis.
Good morning, everyone, or good afternoon. It's really my pleasure to be here. I'm just going to start to share my slides. Are you able to see that?
And just go ahead and put it on presenter mode.
How is that? Are you good there?
Just need to, you're seeing your presenter mode, so if you can just do the regular display on the bottom.
Let's see.
Perfect.
Perfect. Okay, great. Well, thank you so much for the invitation to talk to you all this morning. It's really my pleasure. I had the opportunity to hear some of the earlier talks today, and it's just been a really fantastic symposium. So congrats to all of the organization, or all of the organizers, and congrats to the Sim Center on all of the tremendous work that you're doing. So the request was made for me to talk to you guys today about what we're doing at Health and Hospitals to address health equity, as well as what the potential role for simulation is in this health equity space. However, you all are already doing so much within the simulation space to address health equity that I was really excited to see all of the different work this morning. So I'm just gonna start by level setting and making sure that we're all talking about the same thing when we use the words health equity. So health equity means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. And I want to be clear that equity is not the same as equality. So when we look at these three panels, on the first panel, what we're seeing is that everyone is here. They're trying to watch a soccer game. And here, everyone has the same bench. They have the same type of bench in order to see the soccer game. But what you can see is that the person who's really short still cannot see the game. The person in the middle and the tallest person, they are able to see the game. So the assumption with equality is that everyone is going to benefit from the same support. But we can see here that giving them all the same support did not accomplish the goal of everyone being able to see the game. Now, when we talk about equity in the second panel, we're giving people the supports that they need so that everyone can actually see the game. So you see that the shortest person needs to have 2 benches so that they can see over the fence and can actually see the game. And this is what we are working towards, is achieving equity. But ultimately, our goal should really be justice. And in justice, what you can see here is that the structural barrier to seeing the game is removed. So by having an open fence, everyone has a fair shot at seeing the game. So no one needs any additional support. And this is really something that is probably really far in the future, but the ultimate goal is to how do we get to justice? So why health equity? Well, you've heard some talks today already about how important social, demographic factors, race, how different health outcomes you can have looking at each of those categories. And here, when we look at this map of New York City, you see that life expectancy varies depending on where you live in New York City. And why should that be? So in some areas, you see in the darker areas, like here in the Bronx in red, and in some areas of Queens, you see that life expectancy is less than 80 years. However, in other areas, you see that life expectancy is between 82 to 84 years. So living in the same city, depending on where you live, you may have a life expectancy that's 10 years difference. And there were some really wonderful talks already today about maternal mortality and morbidity and all of the work that the Sim Center is doing to address that. But as you can see, unfortunately, Black women and American Indian women have higher rates of mortality and pregnancy-related deaths when compared to white women. 2020, we know, was a real reckoning, forcing us to really have these conversations nationally. So as we saw the COVID epidemic unfold, we saw that there were higher rates of hospitalizations and deaths among patients who were Black, Hispanic, and Asian when compared to white patients. This, along with the murder of George Floyd, which we all unfortunately witnessed, really caused and pushed a national conversation around equity and justice in many areas beyond health. You know, we also had these conversations in education, policing. So lots of conversations that really needed to be had in this country. And really highlighted the amount of work that we still have to do. So we also started to look internally at health and hospitals as to what more can we do. And because we work at a place like Health and Hospitals, where we have as our mission statement, you know, taking care of all New Yorkers, regardless of their ability to pay. We are already a step ahead in taking care of everyone and in trying to address equity. But we can't be complacent just because we work at a place like Health and Hospitals. And so we really said, well, let's start to look at this, because we don't want to be complacent if there's work that we still need to do internally. And we found that there were really still some opportunities for us to really focus our attention on social and racial equity. So we did, so one of our initial things that we did was to really align this with the mission and the vision of Health and Hospital. So in our vision statement, we included the word equitable so that it reads to be a fully integrated, equitable health system, that word wasn't there before, that enables all New Yorkers to live their healthiest lives. Our mission statement remains the same: to deliver high quality health services with compassion, dignity, and respect to all without exception. Our values, our care values remain the same, And we continue to have these strategic pillars. However, we put social and racial equity as the foundation of all of the work that we do. So it is the foundation to our strategic pillars, our values, our mission, and our vision. And we've also included metrics related to social and racial equity in our systems dashboard. Another work that we did is to establish the Equity and Access Council, which I co-chair along with Dr. Sineas. So the mission of the council is to really serve as an advisory group, supporting the Office of Diversity and Inclusion in developing strategies and initiatives to promote equity and optimize the delivery of care and health outcomes for our diverse populations. The council provides leadership and recommends, as appropriate, policies and procedures and programs that will promote the integration of diversity and inclusion activities across the organization. And our focus is to advance racial and social justice by integrating an equity lens into our policies and programs. So just to give you an idea as to how the council is structured, we report up to the Chief Diversity and Inclusion Officer and ultimately up to the Equity, Diversity, and Inclusion Committee of our Board of Directors. We're divided into 4 different work groups, and each work group has a different focus. We have a workforce diversity work group, which is focused on initiatives to attract, retain, and develop diverse talent to our system. We have a workforce inclusion work group, which hopefully some of you are a part of, which really has strategies to promote inclusive practices. And we now have multiple inclusion work groups that have started. And hopefully you've seen some of the emails that have gone out inviting participation into those inclusion work groups. We have an equity of care work group, which has strategies to eliminate racial and social, institutional, and structural inequities. And I'm going to show you a few examples of some of the work that's been happening in this work group, as well as a monitoring and evaluation work group, which is focused on making sure that we have the right metrics to evaluate the need as well as program effectiveness. So within our equity of work work group, one of the things that we really talked about and which I've worked on with my team in Pop Health is to make sure that we have the data in order to be able to understand and to be able to identify where disparities might exist. So one of the things that we've done is to really make sure that our disease dashboards, specifically our chronic disease dashboards, have race, ethnicity, and language displayed. In addition to race, ethnicity, and language, you can also look at the data according to payer, age, or sex. So in this dashboard, I'm just showing you is looking at A1C control by race and ethnicity. And if you go to the Pop Health dashboard, you can you can see other illnesses. You can see this data for hypertension. You can see this data for COVID vaccination. And it really helps us to understand where there might be disparities. So for example, here, we see that when we look at diabetes control, which we defined as an A1C less than 8%, we see that Asian Native Americans have a higher rate of diabetes control. A higher percentage of these patients have their diabetes under control as compared to our Hispanic population. And so this doesn't give us answers as to why there are differences, but it just lets us know that there are these differences. And then it allows us to start to think about why might there be these differences? How can we look at this data differently? And what are the opportunities that we may have in terms of thinking about how do we start to investigate this further and address this? One of the other things that we've worked on as a system is as our medical and racism initiative. And this is really how we are thinking about, as a system, how do we look at how race is used in our system, and how do we eliminate race, particularly from some of our clinical algorithms. So some clinical algorithms have historically included race, and we've used race as a part of these algorithms for many, many years. That's how we were taught, that's how I was taught in medical school. And now we've really been looking at them more critically to say, well, was race really needed in there? And is the inclusion of race doing harm? And so we've embarked on an initiative to remove algorithms from our system that use race. So one such algorithm is kidney function. Another algorithm is looking at vaginal birth after C-section. And both of those we've eliminated from our system. So in terms of kidney function, we have an algorithm called glomerular filtration rate for the non-clinicians. This is a very common blood test that's reported on that tells us someone's kidney function. And the way this was historically calculated is when you put Black into the calculation for kidney function, when someone entered Black race, then that would make someone's kidney function look better than what it actually was, about 16% higher than what that kidney function actually looks like. So you might wonder, does this actually really make a difference? And the answer is yes, it makes a difference because unfortunately, what it can do is delay the care that a Black individual might get if their kidney function is artificially more elevated or looks higher. So this is one challenge that we've seen that we had, and we've removed it. So now race is no longer in the equation. So regardless of your race, when you get your kidney function test measured here at Health and Hospitals, you're going to get the same result, whether or not you are Black, white, or any other race. And that is an important systemic change for us to have made. Similarly, for vaginal birth after C-section counseling, this was also something that our OBGYNs got rid of. They do not look at race as a reason to counsel someone as to whether or not they ought to get a C-section. They look at overall risk, but not looking at race. And there are many ways that you've already demonstrated how simulation training can impact health equity. Simulation-based education is a particularly germane strategy for addressing the difficult topic of racism and implicit bias due to its immersive nature and the paradigm of structured briefing. And I know you guys have already mentioned this. I was so excited to see the Black mannequins when you all were presenting on the maternal mortality earlier, because that is a really important part of it, is to just have mannequins that look diverse. And using standardized patients with diverse backgrounds is also really critical because that debriefing and how you develop the communication scenarios and the debriefing after those communication scenarios can really have true impact in how we address health equity. Also, it's important to use standardized patients who have stigmatized medical diagnoses. So, for example, patients who have obesity are often stigmatized because of their weight, and they receive lots of stigma and bias from their providers. So thinking about how you build these types of scenarios with community members with lived experience and who are stigmatized is really another important step. And for us in population health, we're not surgeons and we're not OBGYNs. And so we have to think about other ways that we might be able to understand what our patients are experiencing. And so one other opportunity for simulation are things like poverty simulation that helps us to kind of mimic the experiences of our patients going through a day of having to deal with various social service agencies or homelessness or accessing things like SNAP, for example. So I think this might be another opportunity for us to really think about beyond simulating different medical scenarios, but simulating some of the social needs that our patients have.
And I think I'm actually over time, so I am going to end there. And I don't know if there's an opportunity for questions, but really congratulations on the amazing work that is happening that you all are doing. And if there's time for questions, I'm happy to take some. Thank you.
Thank you so much, Dr. Nicola Davis. There will be a panel after if you're able to stay on. But thank you so much for that amazing presentation highlighting diversity, equity, and inclusion and how we can incorporate new ways into our simulation practices in our system. Good afternoon. My name is Kimberly Campbell Taylor, and I'm the Director of Nursing Simulation here at New York City Health and Hospitals. I'm humbled and honored to announce Ms. Kelly Davis as our next speaker. Ms. Kelly Davis is the Executive Director of New Voices for Reproductive Justice, a nonprofit devoted to health and well-being of Black women, girls, and gender-expansive community through voter engagement, leadership development, and community organizing. Before New Voices, Kelly served as Chief of Birth Equity Innovation at the National Birth Equity Collaborative, which creates solutions to optimize Black maternal and infant health through training, research, policy advocacy, and community-centered collaboration. Prior to joining this program, she also led a series of initiatives for the New York City Department of Health. She also helmed healthy eating and active living initiatives and catalyzed New York City's first HIV public awareness campaign, totally focused on women, and served as one of the founding members of the Center for Health Equity. She conceptualized the family wellness suites, community respites, and healing spaces for parents and for children. She has also directed and spearheaded planning, implementation, and oversight of several special initiatives, including severe maternal morbidity and mortality initiatives, supporting 14 maternity hospitals, and a long-term institutional transformation process that addresses structural racism, bias, resilience, and trauma-informed care. She also is the co-founder and chief equity officer of Kinship. This is a boutique consulting firm that supports healthcare and public health transformation through evidence-based practices rooted in actionable principles of trauma and resilience-informed care and anti-racism. Kelly holds a Bachelor's of Arts from Princeton University, where her senior thesis explored how Black women and Latinas experienced contraception in the 20th century. And she also earned her master's in public health degree from NYU's Wagner Graduate School of Public Service. I love that she says none of these degrees or credentials have taught her more than moving through the world as a Black woman with Southern roots. It is my honor to announce Ms. Kelly Davis.
Thank you so much. I'm going to work on sharing my screen. Just give me a second. Hold on one moment. I know that there's a lag. I'm having a little bit of a hard time. I know there's been some technical difficulties earlier, and so folks would just extend 1 second to me. I hope to be able to start my presentation shortly.
We would just like to thank everyone who was in attendance today for your patience as we give Ms. Kelly Davis a moment to log back in with her presentation. Thank you.
We're going to go ahead and try to get her slides up through us. So just give me 1 second. All right, Kelly, just tell me when you want me to advance.
Okay, so thank you so much. Again, my name is Kelly Davis. I'm very pleased to be here today. I'm sorry for that technical difficulty. 2 years into this woeful pandemic, I still haven't figured out how to work WebEx, my least favorite platform. I'm pretty sure many of you share that belief, but I'm happy to be here with you today. I'm the Executive Director for New Voices for Reproductive Justice, along with the co-founder and Chief Equity Officer for a boutique consulting firm focused on working at the intersection of racial equity and trauma-informed care for healthcare and public health systems. I'm hoping that this echo begins to recede. So we'll go to the next slide. A little bit about what we plan to discuss today. Again, I'm sorry for the echo. I'm not exactly sure how I can address that.
We're not getting an echo. You're good.
Oh, good. Great. Sorry, I'm getting an echo on my end. So a little bit about me, the crisis of apathy, which I'm so happy to have gone after Dr. Davis, who explained what health equity is, the difference between health equity and justice. And we're talking a lot about social justice movements now, so moving past just looking at differences. We heard earlier today from Dr. Diaz around the differences between disparities and discrepancies. And I really appreciated Dana's earlier conversation and presentation related to the crisis of apathy in healthcare. So after talking a little bit about the problem or issue, which we heard a little bit about throughout the day, I'm going to talk about the promise of empathy in healthcare simulations, where we really think not just about technical expertise, but what does it mean to simulate treating everyone as a member of our own family, as a human being with the same voice and choice that we have. And then last but not least, talking about the health equity as a practice. Oftentimes, we treat health equity or implicit bias training as a one and done endeavor. I've had a presentation on racism. I'm done. I don't have to really think about this ever again. I'm here to tell you that nothing could be further from the truth. In order to really have the healthcare system and for H&H to really embody its mission, we have to work on creating small, sustainable actions every day at every level of leadership and not be focused on getting things perfect, but improving our understanding and our alignment with the communities we serve. Next slide. So a little bit about me. I wouldn't be where I am today without H&H. Point blank, period. For the last over 10 years, I've been dedicated to addressing racial and ethnic disparities in healthcare, primarily focused on obstetric and gynecological care. And I'm very, very proud to see how many folks in the OB units across H&H have really become the creme de la creme of simulation excellence, as was demonstrated for all of the awards that OB folks attain today. On the left, I have my spiritual foundation. which are the midwives of the H&H hospital system. The real lifeblood, and midwifery is a practice that really embodies empathy at the core function of its duties and patient-centered care. Right there, you see Helena Grant, who is one of my closest advisors, who is a stalwart for really addressing not only structural racism, but other spheres of oppression inside of clinical care, inside of H&H, along with one of our former midwives, Pat Loffman, who was at Harlem Hospital for several decades before the midwifery service there was decimated. So why have I really devoted over 10 years of my life to addressing racial and ethnic disparities, particularly as it relates to gendered healthcare inside of public hospital systems, including H&H? Well, my purpose is my past. And as you can see there on the right-hand side, is a picture of baby Kelly with my nuclear family. And I grew up in a family of primarily Black clinicians. There on the left is my mother, who is a neonatal nurse, very similar to the wonderful Kimberly Campbell-Taylor, who runs a great deal of our simulations here at H&H. And my father was the first nephrologist of African descent in the whole entire state of Mississippi. And so when we talk about how racism has been enshrined into the field of medicine, proving that Black people are biologically different and not treating race and gender as what they are, social constructs, that has had a direct impact on not only my, but my whole entire family's lineage, as I've had a first front row seat into looking at how structural racism impacts not only communities, but also folks that work inside of clinical care settings. And so I think that that's, we tend to think really about the communities we're serving, but the truth is the fruits of the community health that we see across New York City is coming from the roots of the tree of our healthcare system. And everything that we find in our community, we find inside the hospital. So if xenophobia is in the community, it's in the hospital system. If Islamophobia is in the community, it's in the hospital system. And I got a really good chance to understand that, seeing how my parents had to fight racism and sexism in their job, in their lives, and still try to address it in community care. Next slide. We've heard a lot today about the presence of empathy and the need for empathy in simulation. And I'm here to tell you, the root is that we're in a crisis of apathy. And H&H has really been filling the gap for what it means to have a society that where cruelty, as Clint Smith says, is often the point. Next slide. Public hospitals exist because of societal apathy and neglect. Oftentimes, we think about individual actions that we can take as providers, as public health practitioners, but the truth is that the playing field is unlevel from the get-go. We have a segregated healthcare system across our country, but certainly inside of New York City, where certain private hospital systems are allowed to set up faculty practices, grow buildings, and really exclude certain kinds of insurance, including Medicaid, which really in our city is like putting up a whites only sign to your clinic. Also, our fiscal imbalance is built into the system that continues to rob our public health infrastructure and safety net hospitals from the ability to provide the same standards of care that often are found in more well-resourced settings where Black people often do not have access to, or undocumented people do not have access to, or poor folks do not have access to as a function of structural racism. The amount of quality care and the fact that we're even sitting here talking about the excellence of simulation in the nation's largest public health system is a miracle, considering the fact that Medicaid reimbursements never allow public hospital systems to reap the rewards or even break even on costs, something that is baked into our system. And that is reflected in pay inequity. Right? Why do folks leave public service in public health and hospital systems when they can go to academic medicine and often make 2 times what they are making in the public hospital system? Why, when we have to legitimize within public health and private and public hospital systems, increasing our staff, right? When other folks are able to hire travel nurses in less than 72 hours. So a lot of what we're seeing in our system, in our communities, is actually the system is working as designed. And so we often tend to think of individual actions like, oh, I'm going to implicit bias training, when the truth is H&H is filling the wide gap for people that have been not only left behind haphazardly, but have been willfully pushed through the cracks through a whole host of things, including a global and national context. I've been working in the maternal and reproductive health field for over 15 years. And we know that what happens as Roe v. Wade is on the verge of falling, what is going to happen to reproductive health care as folks leave other countries and other states to come access our public health hospital system, because when Roe v. Wade or states are coming up with all these bills that affect health care and the reproductive rights, particularly for priority populations like women, trans folks, and folks of the LGBT community. And then, of course, we talked a lot today about the overexposure to health risks. Poverty, discrimination, unstable housing, community violence, all the things that Dr. Davis was talking about really contribute in the discrepancy of life expectancy across different zip codes and different communities across our city. There's over a 10-year difference in folks that are living on the Upper East Side in Manhattan versus the South Bronx. And we know that no one's health status should be determined by where they live or what they have access to. Next slide. So while we have these structural issues that actually foster inequity, right, the truth is they're also exacerbated on an organizational level. And this was before COVID, right? But it's only been exacerbated since the COVID-19 pandemic, right? If you've had to deal with budget cuts, I'm sure you have. Racist policies and practices, we'll talk a little bit about that. Mandates without resources, right? We often had to test folks during the COVID-19 pandemic, provide support, often when we were dealing with really a scarecrow level of staff. Technology demands, we've seen what it means to translate to EHRs, what that means for our patients, paperwork demands. And then Dr. Davis and others earlier today talked about actually like exposure to community violence inside of the hospital. So listen, everything again that's happening in the community is actually happening within the organization. If the community is having a heightened exposure to violence, that's happening not only to our patients, but also to our practitioners. Next slide. The expectation that we can be immersed in suffering and loss daily and not be touched by it is as unrealistic as expecting to be able to walk through water without getting wet. By function of serving the folks that society has woefully and willfully neglected and left behind, who were disproportionately affected by the COVID-19 pandemic. Our healthcare system is soaked soaked in suffering, soaked in apathy, soaked in entropy, soaked in discrimination. And the truth of the matter is that organizational leadership research shows us that we are more likely to be changed by systems than they are to be changed from us. And so that's why the importance of practice, of simulation, is so important, because it's really one of the only tools we have to actually dry off as we are besieged through the tides of experiencing the woeful pandemic and all of the life circumstances that make folks or the population that we serve inside of public health and hospital systems the sickest out of all the populations in New York City. Next slide. So biases as blind spots. I had a video here, but really it's illustrating some of the things that we've heard earlier today. Some of what we have in our society has been coded into us, and it's not a part of things that we are choosing. And one of the things I have found continuously concerning in the way that we talk about biases in our society and currently in the healthcare system is that we talk a lot about implicit bias. And I think that we do that in an effort to make certain kinds of people more comfortable. But the truth is, implicit and explicit bias is experienced the same. It doesn't matter what our intentions are. It matters what our system's consequences are. And so really understanding our blind spots, which biases are, right? We receive, particularly in healthcare, millions of bits of information every second and only have the capacity to really process 40 bits of information at a time, meaning that we divert to scripts that our society has really encoded in us that says certain kinds of people are less safe than others. That a fat person equals a sick person, right? That only a woman can become pregnant. And we use all of these things to make clinical diagnoses that sometimes actually fracture the bonds of health and respect that we know are needed for our community members to trust us and really embody the full health potential that we know is a human right. Next slide. Next slide. Yeah. So oftentimes we talk only about structural racism and bias. I think since 2020, the year that I think generally people understood that racism existed, even though in this country it's been going on for over 40 years, we've really had a myopic focus really just on racism as the sole factor of oppression. And while it's very clear that racism is an organizing principle for American society since its founding, since the roots of medicine, I often start off these talks really thinking through the ways that medicine over time, over a period of hundreds of years, has really enshrined, as Dr. Davis said, including the ways that we think about it today, the idea that certain people are biologically inferior to others. The truth is that across the country, we're seeing often multiple ways that disadvantaged folks are being targeted through policies that have a direct impact on healthcare access and uptake. I'm sure across the country, you've seen what we're calling don't say gay bills, or the strictures or restricting of trans kids from accessing healthcare, sometimes even trans adults, criminalizing mental health and physical support for folks that are existing outside the gender binary, along with certain racial ethnic groups that have continued to strive access quality care in settings where it's often unavailable or unappealing, inaccessible, and not the highest quality of care. So I say this to say each one of us has privileged identities and disadvantaged ones. Even though I've experienced racism as an American that's descended from enslaved Africans, the truth is that having degrees from Princeton University allows me privilege in certain spaces, the ability to physically walk, right? Some of our facilities, we have elevators that are broken for months at a time. What does that do for folks that are differently abled? And how, when we think about the ways that we are both privileged and disadvantaged or subjugated, how can we use the ways that we are disadvantaged among several of our identities to really become proximate to the suffering of those that are most marginalized in our society, which often tend to be folks that are queer, Black, undocumented, and all of the folks that H&H continues to serve. Next slide. So simulating social justice really depends on really thinking through the ways that biases are exacerbated. And the science is clear. Certain conditions exacerbate biases, including time pressure, fatigue, confusing situations, cognitive overload, or lack of attention to detail being paid to the task. And I'm sure if you're working at H&H, what is your day like? Time pressure, fatigue, vague or confusing situations, too much information at once, or cognitive overload. And so that's healthcare in general. When we only have 15 minutes to a client, right? When we have clinic days and folks are late, meaning that we're staying late. When we're down staff because we have staff members that lost their lives or have been disabled off and on because of their exposure to COVID-19 as a function of their job. And so oftentimes when we're working with healthcare to address biases and racial discrimination, we're often told they're bigger fish to fry. But the truth is, if you stay ready, you don't have to get ready. And times of crises like the COVID-19 pandemic are not the time to really start thinking about trauma-informed care and anti-racism. Why? Because in states of emergency, we're actually being more racist. Our systems are being more exclusive than they are when we have the ability to think, when we're well-staffed, when we're rested, which we all know is not really the way that public hospital system or our tiered hierarchical healthcare system is structured. On a good day, let alone during the COVID-19 pandemic, let alone during challenges to homelessness and violence exposure that our communities are all experiencing, which we know have health consequences across the life course. Next slide. We've talked a lot about this today, but our biases, irrespective of whether they're implicit or explicit, right? And New York City loves to pretend that we're a place, we love to tell that we're a melting pot, despite being one of the most segregated cities in all of the United States, with one of the most segregated hospital and healthcare systems in all the United States, and one of the most segregated school systems and neighborhoods, right? We only second to Chicago, but yet we continue to think that biases often don't play a factor in the ways that we make clinical decisions and the way that we structure society, from the policy environment to interpersonal dynamics. Despite the fact that healthcare and social service providers are proven to have the same biases as the general population. There's a myth that we have as New Yorkers. There's a myth that we have as clinicians that, oh, I work at H&H. I can tell you, we're a safety net hospital. We're dedicated to serving folks, and yet the data shows that folks with similar risk factors, particularly in obstetrics and gynecology, which I've studied on for the last over 10 years in New York City, that we have folks coming in different race ethnicities that have drastically different outcomes, even with control for BMI, even with control for all the things that we say are protective factors. And yes, that has to do with society, but it also has to do with our own believing of the denial of healthcare systems being a place that is automatically anti-racist because we said that we are going to do no harm. So research has been pretty clear that positive attitudes toward white people and negative attitudes toward Black people are found even in healthcare settings, even in higher resource environments that have higher social service settings and infrastructure like New York City. That we make assumptions around patient behaviors. We heard a lot about fat phobia right earlier today. We've heard a lot about pain management and the amazing work that H&H has done to really simulate or address root causes for racial and ethnic disparities and severe maternal morbidity and maternal mortality. But we still hear over and over again that we are not taking symptoms seriously, right? And so our systems can only be as good as really the dedication and the practice to anti-racism that our leaders and leaders and everybody provides healthcare, from the person who answers the phone to taking our blood pressure to the physician. And we all have a role to play in really thinking through how do we undo some of the biases that are encoded in healthcare that we are seem to deny that we have, despite the fact that healthcare systems are made up of individuals that have the same exposure, oftentimes because of functions of privilege, right? Less in common with the communities that we're serving, meaning the higher possibility of having bias. Next slide. So how does that manifest at H&H? And I want to tell you that over training, I've trained nearly 1,000 healthcare providers in H&H, primarily in maternity services. And these are just some of the things I've heard that have let me know that bias is alive and well, even when we're trying to read it through simulations and other quality improvement and quality assurance endeavor. I have to call the language line. How many times have we heard that? Right? I have heard that numerous times across the hospitals in New York City. And every time that we say that, we're communicating through our body language, we're communicating through our attitudes that someone who has a different language than we do is actually an imposition to actually care for them, despite the fact that we are home to the most diverse population of any American city, right? I've often heard physicians plotting to entice more desirable patient populations. Oh, if we can get more people from Methodists, we can improve our rates. Instead of really thinking through what needs to happen at the clinical settings where we serve patients, to really think through who is already paying our bills, who are we dedicated to serving, and that actually improving outcomes is not contingent upon enticing people who we think are better adherent patients, better profile of patients to our own settings, right? Constantly complaining around not adherent or not compliant patients without any documentation for actually why the person is unable to follow clinical advice. Oftentimes, calling someone non-adherent or non-compliant is where we just encode bias into our electronic health records and allows us as subsequent clinical providers to write that person off as a quote unquote either frequent flyer or lost cause. Discriminatory practices. We've talked a lot around earlier today around how racism is actually ensconced and enshrined in some of our policy and practices. In my field, I've been in trainings in H&H hospitals where folk have admitted to discriminatory drug testing in labor and delivery, right? As a function of the biases that we all have in thinking through who uses substances and who doesn't. And we know it's very clear, the psychology is actually that all races of people use drugs equally. And however, who is criminalized for which drugs the most often has a root inside of clinical systems. Snow camps. We service the most diverse patient population in the nation. And yet, when you look at who are CEOs of certain hospital systems, who are chairs and vice chairs, it doesn't really reflect that reality. As we go towards the hierarchy, we see all the MAs will often be women or queer people or folks of color. And by the time we get to the often CEO of the institution itself, things get older, whiter, and maler, irrespective of the patient population we're trying to serve. So that means that we have all these things that are enshrined in the clinical system itself. And then unequal distribution, even within the system itself, right? The way folks talk about Harlem Hospital is very different than the way they talk about Bellevue. And I have to ask, why is that? Right? The way we talk about Lincoln is very different than the way we talk about Elmhurst. And the clients know this. It happens in the community, but it also happens in the facilities too. When we think about how our resources dedicated in the simulation center, making in situ simulations happen, going to where the sites are is one key point in saying, actually, no matter where you serve inside of our hospital system, you have the same right to excellence, the same right to support, the same right to practice as anyone else at any other of the facilities. But it's baked into the system and our community members know it. And then lastly, code handoffs to supportive services like eviction prevention, like screening for violence. We screen, but then often don't do a warm handoff. And the warmest handoffs we do have are often to the criminal legal systems that we know from our communities actually traumatize folks. So ACS, sometimes the policing system, sometimes security. And it's very telling in trainings when folks are admitting to really making more calls to ACS or police than they do to referrals to quality services in the community. And then last but not least, how does it manifest in places like H&H and other public hospital systems using social determinants to advocate responsibility for outcomes? Well, you know who we serve, girl. So what can we do about it, right? It's very true that health is determined outside of healthcare alone. However, healthcare cannot abdicate its responsibility because racism and other spheres of oppression exist in society. We're the last stop, which means we have to be often most vigilant to addressing some of these root causes where other aspects or other facets of society cannot afford to be as relaxed as we can be, or the other way around. Actually, we actually have to be the most vigilant because we're picking up the slack where education, where housing, where violence prevention, all of that is found in the hospital, and we're often the last stop, which means we have to be the most vigilant when addressing biases and trauma inside of our healthcare systems. Next slide. So while there is a crisis of apathy, there's often a promise of empathy. And we've heard a lot about how empathy is embedded in simulation today. And I'll just go through very quickly a little bit around empathy in healthcare and how it can be used inside of the H&H hospital system. So next slide. Yeah, next. Yeah, one more. Yeah, keep going until all the bars. Two more. Thank you so much. So we can handle some stress with enough resources to cope. And so that's what empathy is about. By making sure that you and I have some kind of access to the proximity of your life circumstance, it's able to give me just 10% more capacity in order to meet your needs. And sometimes 10% is enough between life and death. I'm not the kind of person, I don't believe in like self-care or thinking of one-off trainings as being, I don't have delusions that changes systems. Healthcare needs a total overhaul in this nation, actually across the globe, but particularly in this nation, and then also in this state and city. However, empathy can give us enough support and resources to be able to create different dynamics, different opportunities for connections with the people that we're serving, while we still mobilize and organize to address the root causes of the ways that structural racism and other spheres of oppression are baked into our society today. Next slide. So this was a video by Brene Brown, who's talked a lot about empathy and vulnerability. And empathy is really the practice of humanity. And the truth is that for many of us in public health education, medical education, empathy is actually being taken away from the way that we think about our care. To me, it's very telling that it was, I think, 2020 before most hospital systems even were able to get brown mannequins for simulations. Right? 2020, before that took place, before we were able to have simulations in different languages, right? And one of the most diverse cities in the world. And so by thinking through the practice of being human, affirming other folks' humanity, even if it's different from yours, and becoming proximate in the community that you serve, even if you don't live there, that is really our only hope in creating a patient-centered healthcare, specifically while we have a society that continues to structure opportunities and disadvantages to really limit the health and well-being of certain key priority populations we're dedicated to serving. Next slide. So mitigating the efforts of bias, really in the clip, Brene talked about shifts in perspectives. And for me, this has been a really key shift in thinking of what's wrong with this person. Often in public health and in medicine, we're taught to be, we diagnose, right? A plus B equals C. However, when we take the time to think through what's happening with a person, what's happening with their community, it opens up the space to really think through creatively around different solutions that we can offer that are not just based in the didactic model, which has problematic implications, particularly for folks that are outside of what we think of as healthy, normal, and good. Next slide. So all of that to say, improving technical expertise without empathy is an absolute waste. And we've seen that in my field of obstetrics and gynecology, maternal mortality. In California, what happened when we focused just on hemorrhage carts, right? Just on screening, right? But didn't focus on treating folks with respect. Actually, racial and ethnic disparities got worse. Right? So for the people that we saw as human in California, they benefited from the technological advancements. They benefited from low aspirin therapy. They benefited from screening. They benefited from changes to the blood banks protocols. However, for folks that we didn't see as human, technological advancements and really just thinking of stimulating just emergencies without the human component will never ever save the lives of people whose humanity we don't affirm. Next slide. So in closing, I'm gonna talk a little bit about practice as praxis. You know, the irony is, what do folks say about medicine? With my father, he doesn't achieve medicine. He doesn't perform medicine. He practices medicine. My brother practices medicine. Many of you practice medicine. You practice midwifery. You practice nursing. And yet, we don't practice. Practice is an everyday devotion, not to getting it perfect, but to improving. And that's what the Simulation Center, I think, really exudes. That's what the Simulation Center is truly excellence in thinking through practice as praxis. Next slide. So reducing bias and fostering empathy is a practice, right? It includes being aware of your own biases. Earlier, there was a slide with the Harvard bias test. I take it every day, every year on my birthday, because my biases change based off of what the narratives are in America, right? Focusing on partnership building. If you work at H&H Hospital and you cannot name 3 community-based organizations that are working in your area of expertise, maybe you really need to think through the ways that you are showing up inside of your clinical care systems. We've talked about stereotyping all throughout the day, and the importance of self-regulation. We cannot create spaces of healing for others unless we're dedicated to also healing ourselves, including understanding when we are triggered, when we are tired, when we are grieving, and how that is impacting our clinical decision-making process. Next slide. So part of that, actually, we have to start at the bottom. I appreciated Dr. Davis's slide around racial equity being the basis for everything that H&H is dedicated to doing in its new mission and strategic plan. And that includes physical and emotional safety. When folks are not safe in their communities or in their clinical systems, they don't even have the ability to take our advice. When someone is homeless, they cannot hear what you are saying around healthy eating, active living, or medication adherence. So promoting safety and stability is really the key first step into thinking through better clinical outcomes focused on the population that we're dedicated to serving. Next slide. Empathy at every level of leadership. These are just some key, my time is running up, but these are some key examples and thinking through how would the COVID-19 pandemic been different if we thought around policy and equity audits before getting into a crisis, right? Crisis planning before, emergency drills, simulation of being understaffed and overwhelmed, right? Before that's happening, right? So what happens when your nursing staff is 50% down? Some of our simulations happen assuming that we're fully staffed. And we understand that that hasn't been the case through COVID-19 pandemic. So really empathy should be engendered at every level of leadership because every person is responsible for creating the care environment. Next slide. And in closing, that really looks like a variety of ways that I've heard, and I'm so proud to have been a part of the maternal mortality work that New York City has done, and really in thinking through not only just the clinical provision of technical excellence, but creating multidisciplinary care teams, right? It was very telling that the AMA during a pandemic really talked about scope creep for physicians, when the truth is that we need more multidisciplinary care teams to really address the complex needs of the communities we're serving, right? Improving communication. These are often all things that we can do for free. And so the idea that we need more resources to treat people with respect is not true. And the excellence that H&H does through its simulations every day, it really shows that. So my last slide, I just really want to thank you for giving me this opportunity. I went a little bit overboard, but I'm dedicated to really thinking through trauma-informed care, anti-racism, anti-oppressive care in this city that I've called home, just like as you are. And I love and appreciate everyone at H&H for everything that they're accomplishing, and Godspeed. We're continuing to do the work that needs to be done. Thank you.
Thank. Oh. Hello. Oh, thank you so much, Kelly. It's so powerful and definitely gave me some new thoughts about different things to think about in terms of doing simulations. I'm going to pass the microphone over to Dr. Felicia Hercules, who's going to introduce our next speaker.
Thank you, Michael. Good afternoon, everyone. Thank you all for being here for such an important topic. My name is Felicia Hercules. I'm an emergency physician and a simulation site director at Harlem Hospital. Today, I have the privilege of introducing Dr. Komal Bajaj and Ms. Ariel DeRoche. Dr. Bajaj is a graduate of Northwestern Feinberg School of Medicine. After medical school, she went on to complete her residency in obstetrics and gynecology and a fellowship in reproductive genetics. Dr. Bajaj felt drawn to education and fell in love with simulation as a modality for not only teaching, but also to advance healthcare quality and safety. Her passion led her to pursue a master's in health professional education from Massachusetts General Hospital Institute of Health Professions. Dr. Bajaj's impressive pedigree and commitment to safety has not gone unnoticed. She sits on the board of trustees of Harvard's Center for Medical Simulation, the advisory board for the Foundation of Healthcare Simulation Safety, and on the external advisory board for the Joan Marks Graduate Program in Human Genetics at Sarah Lawrence College. I've had the honor of hearing Dr. Bajaj speak in the past, and it's amazing that someone so accomplished can also be so humble. Dr. Bajaj will be co-presenting today with maternal health advocate Ms. Ariel DeRoche. Ms. DeRoche has a master's degree in epidemiology from Columbia University. She has a profound passion for sexual and reproductive health research and advocacy with the goal of making birth safe and satisfying for all. When she's not working on research, Ms. DeRoche uses her knowledge base to support families in New York by serving as a birth and postpartum doula. It's with great privilege that I welcome Dr. Komal Bajaj and Ms. Ariel DeRoche. Thank you.
Thank you so much, Dr. Hercules, for that introduction. And building so beautifully on the talks that have gone before, what Ariel and I are really hopeful to showcase is just the power of the maternal mortality reduction program to think differently and apply a diagnostic safety lens to our work. And it goes without saying that there is still there is so much to be done to improve maternal morbidity and mortality, especially in Black and Brown women. And the MMRP program and the tremendous efforts of Dr. Wilcox and teams across health and hospitals have made a difference. And yet there is still much to be done to deliver the type of safe and equitable care that we'd like to see for all birthing persons. As a result, what we'd like to do is advocate for the application of a diagnostic safety lens to maternal mortality, morbidity, and mortality reduction efforts. And so just to make sure that everyone's on the same page, diagnostic safety, according to the National Academy of Medicine, is the failure to establish an accurate and timely explanation of the patient's health problems or communicate that explanation to the patient. Similarly, diagnostic error is a diagnosis that is missed, wrong, or delayed. And certainly, there's a lot that's been written about diagnostic safety outside of obstetrics, particularly in internal medicine. And I think, our goal is to harness simulation to include diagnostic safety into the lexicon of OBGYN professionals. Over 250,000 diagnostic errors occur every year, and 1 in 20 will experience a diagnostic safety error, and many of those can be potentially harmful. Diagnostic safety and error in obstetrics is very understudied. There have been a few small studies, none of which have been in the United States. In a small study in the Philippines, diagnostic errors are 3 times more likely to cause complications in pregnant women. In another small study in Kenya, failure to properly diagnose a condition contributed to about 58% of errors in emergency departments as it relates to obstetric events. And certainly, improving diagnosis over and over again has been shown to be a viable strategy in improving outcomes. And so the example that we sort of deployed simulation to study diagnostic safety events is a tremendous work that has been done by the MMRP simulation team related to postpartum hemorrhage. Just to remind everyone that hemorrhage is cumulative blood loss greater than 1 liter. It is a leading cause of maternal death worldwide. And unfortunately, the vast majority of PPH or postpartum hemorrhage-related deaths are avoidable. And this graphic, after many, many states have established maternal mortality review committees, it's clear that 70% of deaths are preventable. So we need to do more. And unfortunately, when people are reviewing these outcomes, it's often through a retrospective scope, knowing the outcome, as well as sort of relying heavily on documentation. And what we wanted to do was really think about the diagnostic process and look at what's happening with the diagnostic process during simulation. So a real-time look at this diagnostic process, which really is a team activity that, there's uncertainty, it sort of plays out over time and requires tremendous communication, not just between healthcare teams, but with the healthcare team and the patient and their, support individuals as well. And so this is a schematic of the diagnostic process, right? Someone has a problem, they sort of choose to engage with the health system. There's a whole host of things that happen, right? History taking, physical examination, testing, referral. The diagnosis is communicated again between healthcare teams, and then there's treatment that occurs. And there's a lot that has been written in the literature about how to sort of perform the diagnostic process as it relates to maternal hemorrhage. But clearly, it's not working all the time. And we think that this is a tremendous interplay between the diagnostic process itself, as well as that work system, whether it's the team members, the tasks that need to happen, some of our tools, the organizational culture, as well as the physical environment. And just to remind us that, the diagnostic process, while diagnostic safety is not necessarily within the lexicon of most OBGYNs, we can sort of see here that the key components of the diagnostic process as it relates to maternal hemorrhage very clearly fit into this existing framework, which has been well described by the National Academy and others. And oftentimes, when there are things that don't go so well, it is as a result of clear failures within various elements of this diagnostic process. Recognizing that there is still much to be done as it relates to the application of a diagnostic safety lens to maternal mortality, myself, Ariel DeRoche, and Dr. Dina Goffman from NYP Columbia actually wrote an issue brief about the status of the science and really articulate a very robust research agenda around diagnostic safety in childbirth. Extending that work through support from the National Academy of Medicine Scholars in Diagnostic Excellence, we chose to really, again, harness simulation to identify what types of diagnostic errors that were occurring. So here's a schematic of that proposal. The first was to develop an observation tool to really look at these hemorrhage events. The second was to characterize the nature of diagnostic errors that occur. And the third piece is to develop with sort of partners, sort of nursing professional societies and the American College of Obstetrics and Gynecology, sort of a module that helps raise awareness around the most common diagnostic errors that were observed. And so this is our very aggressive timeline, and I'm happy to say that, we were able to establish that tool, publish the AHRQ issue brief, as well as an IHI blog, collect some pilot data, and are in the process of submitting several manuscripts. Ariel is going to take us through the development of the diagnostic safety, the diagnostic tool.
Thank you so much, Dr. Bajaj, on focusing on kind of the what and the why, and I'll talk a little bit about the how. So yes, we created this maternal hemorrhage diagnostic safety tool that would really focus on, in that process of a hemorrhage protocol, where are some of those errors that are occurring for both a simulated and an actual event. We wanted a tool that could be able to be used for both. And so we pulled from a myriad of resources, tools, and instruments that already existed to create our tool. And I'll briefly go through each of those listed on the left-hand side. And so some of these may look familiar to those who are in obstetrics work. The hemorrhage team review and debriefing form, which really focused on was something met or not met, were these critical actions taken, but also focused on the debriefing reflections, which we also pulled into the tool, which I'll show you later. And one thing I do want to note is that this was, the organizing principle of this tool, which we also used for ours, are the 5 R's. And on the next slide, it really goes into the respectful care of So this was also the CMQCC OB hemorrhage toolkit, which we used. The latest version was just released last week, which was very exciting. And we used this to reference our critical actions that we included. Next slide. And so, Kelly Davis really made a huge point about patient care. Are we really engaging with the folks that we are taking care of? And so this was a really important part to include. Also, pulling in our care providers, talking to folks during a hemorrhage case. What are they saying? And are folks still being, included in their care, especially in an emergent situation? And lastly, this is our Safer DX instrument, which really played the foundation for our diagnostic safety. We connected, in the next slide, you'll see how we connected all of our critical actions from the tools that I mentioned earlier to this diagnostic safety instrument to ensure that on the foundation, we were rooted in diagnostic safety overall. And so we created this tool and we used the modified Delphi, which is an iterative process to come to a consensus about a specific topic or goal. And so we had this tool. We met with 3 content experts in obstetrics that serve a variety of patient populations and hospital systems. And with their feedback, we were able to revise the tool, pilot it, and then we also followed up with them again to review our changes. And so we talked about structure. Do we want to use a Likert scale? Do we want to use a binary? Yes, no. The utility, paper versus plastic, right? Is this feasible to do? How is this feasible to implement on a postpartum or labor and delivery unit? And also the content. Were there any critical actions that we were missing? And so on the next slide, so as you can see on the left was what we originally created, and on the right, highlighted in salmon, is that salmon? Are some of the critical actions that we got feedback for that were missing from this, which were really crucial and important. And so here is our tool. Our baby was born. We really wanted to ensure that it included some background information so that anyone, a care provider or a non-care provider like myself, could use this tool in a simulated or an actual event to complete it. And so yes, this is what it looks like. It's not super fancy, which is great. It's simple, really easy to complete, of met and not met, but also a section for observation tools. What are some things that we are seeing as an observer? And also, we know that there's really a lot of richness in the briefings and going through the reflections in that as well. I'm going to send it back to Dr. Bajaj.
Thank you so much, Ariel. And it just was really a labor of love. And I just want to commend Ariel for sort of really the rigor and the passion that she brings to this work. So as was mentioned, again, kudos to the MMRP team who are conducting these simulations. And, we were able to embed observers utilizing this, tool to sort of look at what were some of the sort of diagnostic safety events that were occurring. And again, we use the pilots to revise the tool as well as begin to understand diagnostic safety events. And so we were able to observe a total of 11 events. And again, we wanted to use a very rigorous qualitative analysis approach to really looking at what were we seeing and what were the themes. And so we used a framework theory approach, which is really well described in the qualitative literature, to really look at the observations. And again, just to remind us that these were sort of all of the diagnostic process elements, which include both the timely actions, right, as in the diagnostic safety definition, as well as those communication elements, which are so crucial. What I want to highlight here is that, again, we observed 11 simulations. And if we look at all of these critical actions, when they were unmet, or when there were sort of challenges in achieving those specific actions, what I really want to highlight is that there were different elements of the work system that contributed to that diagnostic safety event. So let's unpack that a little bit more. So what an observer saw was that the hemorrhage cart and room key action was not met. right? And so what you see if you did a retrospective chart review or you talk to someone, days after the event, they'd be like, yeah, the hemorrhage cart wasn't in the room. But because we had direct observation of these events using simulation, we were able to understand that there were actually multiple contributors in different simulations to what we were seeing. One was that it was related to the tasks and that the team member actually left a cart in the hallway. It could relate to the technology and tools that there is no hemorrhage cart at the facility currently and that it's a work in progress. And it could be sort of a component of the physical environment, that the hemorrhage was taking place in a non-typical area, as in the postpartum unit, and that there isn't a hemorrhage cart in the postpartum unit. So all of a sudden now, the symptom of a hemorrhage cart not being in the room can be tackled in multiple different ways. And this is the crucial element of this is the crucial need to apply a diagnostic safety lens to the work that we're doing, because it allows us to really begin to peel away the onion and think differently about the solutions that we need to deploy. So some of our next steps over the next 3 months are to continue to collect observation data. We also now have some clues as to the top three things that we're going to be sort of developing a self-guided simulation around. And again, this is in collaboration with some of our professional societies. And we are in the process, again, collaborating with Dr. Megardician and Dr. Wilcox and all of the teams, additional grant funding to further sort of ingrain a diagnostic safety lens into maternal mortality reduction. Again, both Ariel and I are just the megaphones for this tremendous effort, which has taken many, many people. We want to sort of acknowledge that this is a team sport. We'd also love to continue to keep this conversation going, whether it's via email or Twitter or in whatever forum. Thank you for your time.
Thank you so much, Komal, and Ariel. Is really awesome actually seeing such a huge amount of work put into really thinking about how to make simulation very evidence-based and have an approach that is very strategic, modeling kind of like what we should be doing for a lot of the things that we do moving forward. So thank you so much for doing that. I'm going to actually invite Komal to introduce our next speaker, Dr. Jen Arnold, because they're pretty good friends. So we're going to have Dr. Bajaj go ahead and introduce Dr. Arnold.
Thank you so much, Michael. And just before I introduce Jen, I can't say enough. You're right that rigor in both how we approach learning from simulation and tracking impact is so crucial as we move forward. And I have to say, our next speaker, Dr. Jennifer Arnold, is a just expert in that area. And so, Dr. Jen Arnold received her medical degree at Johns Hopkins. She then attended pediatric residency at the Children's Hospital of Pittsburgh and a fellowship in neonatal and perinatal medicine. She then went on to, again, with that academic rigor, a master's of science in medical education from the University of Pittsburgh. She's a board certified neonatologist, and I'm thrilled that she recently accepted a new position as the program director at Boston Children's Hospital. They're very lucky to have her, and is a newly minted member of the Harvard faculty. She has a whole host of research interests and is really just a warrior for the use of simulation to advance healthcare quality and safety. I've seen her speak in numerous national and international forums, and it is always a treat. She's on the executive boards for several organizations, including the Center for Medical Simulation in Boston, the Inspire Network, and OpHeart, which is a non-for-profit dedicated to improving pediatric care of children with complex congenital heart disease. Dr. Arnold has a rare type of dwarfism, which has involved nearly 40 orthopedic surgeries. She's also an 8-year cancer survivor, having fought a rare type of choriocarcinoma, which thankfully has been in remission, knock on wood, since January 2014. She and her husband, Bill, and their children, Will and Zoe, have created more than a decade of television. I didn't quite realize this, Jen, but it ran for 14 seasons before ending during COVID. Just truly remarkable, the generosity to share sort of your journey, and the experiences that you and your family go through day in and day out. And on a personal note, I mean, Jen, as I mentioned, has been a tremendous advocate for simulation as a healthcare quality and safety tool. And I feel very lucky that to be able to follow in some of her trailblazing steps as a healthcare quality leader. And as Michael mentioned, she is a friend, a colleague, a champion, and a supporter, and we're so glad that she's here today. Thank you for being here, Jen.
Oh my goodness. Como, thank you so much for that warm welcome. Lovely introduction. Oh my goodness. I feel like after hearing that, I want to be me. It is so nice to get to be a part of this conference. And honestly, I can't say enough amazing things about you, Como, in terms of I admire all the work that you do. You are making strides in outcomes for patients, especially when it comes to maternity health and morbidity. And I just listened to your presentation. I'm in awe, as always. So thank you for all that you do to save lives with simulation. All right, so with that, since I like to talk a lot, I'm going to share my screen as well. Will it allow me to do that? I hope. Let's see. Uh-oh. Well, allow WebEx to share your content. Anybody have any recommendations for me? Oh, yay, thank you. Okay, I think you just gave me permission. All right. Uh-oh. So I'm not the only one that's having trouble. Oh. Okay. My apologies. I guess I'm not a... I think I might have the same problem Desiree had. My apologies.
Are you able to go ahead and send the presentation to me real quick?
I can. Hold on. My apologies, team. Should have tested that before, I guess. Okay, Michael, I just sent you a link. Hopefully, it's going to be a drop.
Is it a Dropbox? Is that what it is, or?
No, it's just an email link. If I log in and log out, it actually might work for me. If you don't get that, let me know. It's telling me I have to log in and log out.
Still haven't gotten it quite yet.
Okay, I'm gonna log out and log in to see if it works for me.
Okay. Thank you, everybody, as we've been navigating IT all day. But that being said, post-COVID world, we gotta bob and weave and pivot as we need to. So the content is incredible. So I appreciate you guys hanging on, and we're really excited about hearing what Dr. Arnold is going to be saying. Welcome back. There you go. Uh-oh, I'm feeling it. Welcome. There we go. We can see your slides. Just put it in presenter mode and we should be good. And unmute as well. And while she's getting set up here, I just hope that all these ideas you guys are thinking about how we can go ahead and tackle health equity and really think about where education kind of weighs in and how we can use it as kind of our tool for creating social justice and health justice, et cetera. So I'm really excited about hearing what Dr. Arnold has to say. Are you unmuted, Dr. Arnold?
I am. Sorry about that, everyone.
Beautiful. Perfect. Thank you so much. We're excited.
My apologies, everyone, for that technical difficulty. Well, again, as I mentioned, it's quite an honor to be here. And my topic today, hopefully, is in alignment and going to resonate with some of the discussions earlier in the day that we've had, because I'm going to focus on pushing our boundaries with using healthcare simulation as a tool to help improve diversity, equity, and inclusion. And along those lines, I'm going to share a little bit of my personal story as well. So our goals today are to share my personal experience with, diversity, equity, and inclusion as a person with a disability. We're going to chat a little bit about the state of healthcare simulation as a tool for enhancing diversity, equity, and inclusion. Hopefully, I will inspire you to think of ways that you can integrate diversity, equity, and inclusion into your simulation-based activities. And last but not least, we're going to talk about something a little unique, and that's the use of simulation as a tool for improvement in healthcare systems, processes, and even clinical spaces to help provide not only safe, but more inclusive and effective patient care. So, I am on a diversity, equity, and inclusion journey, as we all are. I sort of feel like I'm probably in a crowd of folks that would agree that none of us are experts yet. I certainly am not. Many of us may feel uneasy, uncertain, and sometimes not even safe to have discussions about DEI. So while I know that we still have a ways to go, I know that we can get there by supporting each other along the way. And really, my goal in sharing my personal story is to help provide some context for having psychologically safe discussions for improving DEI. So this is a picture of me on my very first birthday. As Como mentioned, I was born with a rare type of skeletal dysplasia called spondyloepiphyseal dysplasia type Strudwick. Essentially, it is a rare type of dwarfism that resulted in, about 40 orthopedic surgeries. I'm actually recovering from one right now, almost done from hip surgery. But, despite the fact that I had all of these surgeries growing up, I was definitely the kind of kid that liked to have her cake and eat it too. And I wasn't about to let my disability get in my way to achieving my dreams. And so growing up, I had a lot of things that I wanted to achieve. Like I'm sure each of us in the audience, there's a lot of things we wanted to become when we grew up. I wanted to be a marine biologist, I wanted to be an actress, I wanted to be a cheerleader, or even wanted to be a member of the Mickey Mouse Club. Well, I kind of feel like the top one, though, not only being the most important, but all of them, I feel like I kind of achieved, except for maybe a member of the Mickey Mouse Club, but I'm not done trying yet, so stay tuned. So thinking about that goal, though, of becoming a physician, that was probably, while the most, the one that I chose, it is definitely the most difficult. The odds were essentially against me when I was applying for medical school. In terms of the disabled population in our community, about a fifth of our population has some type of disability. And sadly, I should say, the statistics for the number of physicians with disabilities is much lower. So about 0.2% of medical school graduates have disabilities, and anywhere from 2 to 10% of physicians in practice have a disability. Essentially, this suggests that it's probably pretty hard to get into medical school with a disability, but hopefully a little bit easier to stay in practice if you were to become disabled during your career. So what's interesting, and I'm sure we've chatted about throughout the course of the day, is, in medicine and healthcare, it's so important that our workforce reflect a population of patients that we're caring for. And this is definitely one area that could use improvement. So why is this the case? Well, it's, I'm sure it's very complex and there's many different theories, but for sure, disability within healthcare is somewhat controversial. right? Specifically as physicians, we're supposed to be the ones that help to define and decide who qualifies as having true impairment, who has a disability. And again, when you're practicing medicine, colleagues, sort of feel, I think, and myself included, we may feel because we care for patients with disabilities that we have special insight into what that's like. And that can actually lead to hidden or overt bias or misconceptions about what disabled individuals can do and achieve. And that can make, I think, it more difficult for applicants to get into the field of healthcare. So when I was applying to medical school, I knew it was going to be tough. I didn't know if I'd be able to do it, but anyone who ever told me I couldn't do something only made me want to do it more. So I knew I was going to give it a try, and so I did. And like most folks, I applied to medical school during college. I really wanted to become a physician because I had been a patient all my life. I had a tremendously amazing, talented, and dedicated pediatric orthopedic surgeon, who early on in his career had dedicated his entire focus on persons with skeletal dysplasia like myself, who otherwise were suffering from the skeletal anomalies and deformities, to the point to where many of his patients had never walked until they met him at age 20, or maybe risk of paralysis, and he was able to really make strides in the quality of life for kids with skeletal dysplasia. I had benefited from his care as early as the age of 2. I felt very fortunate to be one of his early patients and to have found him at an early age. And so I knew I wanted to give back to the field of medicine in the way I had benefited. But I didn't know if actually doing that as a physician was going to be possible. But I, again, wanted to be that girl to have her cake and eat it too. So I applied, and like most of us in the audience who are physicians, submitted my application to like 40 schools. And while my, friends, my peers who were pre-med started getting interviews in that secondary application, I was not. And, I compared my notes with my peers. I had similar grades and extracurricular activities and MCAT scores. And in fact, one of the extracurricular activities that I was a part of was something called the President's 100. So I was an elite group, supposedly at the University of Miami, of students who were ambassadors to the president. So I felt like my application should be pretty solid. Well, in my personal statement, I had stated why I wanted to become a doctor. I wanted to care for kids and give back to kids in the way that I had benefited. And I was only 3'2". I, to this day, will never know for sure if that had a bearing on my lack of application or interviews, but it definitely seemed so. I actually, because I was a President's 100, kind of stood out from the crowd in that group and knew the president of the university, who you see in this picture here, Dr. Tad Foote. And during my process of applying, and I was hosting or ambassadoring one of Dr. Foote's events, and he came up to me and he said, hey, Jenny, Jenny back then, how is that medical school application process going? Well, at that time, it wasn't looking so great. I probably had a handful of schools left to hear from, but up until that point, I had not had a single interview offered to me. So I said to him, hey, Dr. Foote, thanks so much. Unfortunately, I haven't had any interviews yet, but I am remaining optimistic. And he said, when are you going to interview here at, U of M? I said, well, technically, I didn't know really what to say here. I unfortunately was rejected from the University of Miami, but I'm still waiting to hear from some more schools, so I'm staying, hopeful. He said, oh, goodness. I said, well, okay, keep up the good work and see you next time. Well, 2 days after that conversation, I got a call from the University of Miami School of Medicine Office of Admissions offering me an interview. I thought, oh no, Dr. Foote, he must have done something. And I said to the person on the phone, I said, are you sure you have the right Jennifer Arnold? Because I'm looking at my rejection letter. And they said, no, we've reconsidered. We'd like to offer you an opportunity to interview. At that point, I really struggled with whether or not to accept because I felt like I did not achieve that interview on my own merit, but at the same time, I really didn't have any other prospects, so what would it hurt to go interview? So I graciously accepted and went on my way. Well, in that interview, it was rather interesting in that my interview at the University of Miami was about 2 weeks later. But before going to that interview, I did get one other phone call, and that was from my dream school, Johns Hopkins School of Medicine, offering me an interview as well. So things were looking up. Out of the 40 schools that I applied to, I got rejected from them all prior to even interviewing, but I had 2 actual invitations to interview. So I went to the University of Miami first, and in that conversation, that interview, it really was a little bit of the good cop, bad cop. At first, I met with an internal medicine physician and a trauma surgeon, and they started asking me about my grades and what I wanted to do in the field of medicine and my curricular activities, and it was all seemingly very normal. And then the trauma surgeon said to me, do you drive a car? How do you do that? And then he said to me, how do you expect to see patients? And I said, well, probably like everything else, I'd use a step stool. And then he said, how are you going to crack open the chest of a 60-year-old MVA victim that comes in through the ER? I thought for a minute, oh no, I don't really know how to answer that. I said, Dr. So-and-so, I think it would be pretty challenging to crack open the chest of an MVA victim as a person of short stature, but I don't really want to become a trauma surgeon. And I said, I do watch ER. And, on that show, I don't know if that was the best answer, but in that show, in the ER, there's a whole team of healthcare professionals. I said, I imagine if I became the ER doctor, I could manage the airway with a step stool or, run the code. I said, or get access with, on the arm. I said, for sure it would be difficult, but I hope to go into a field of medicine where my stature is not a limitation. Well, after that interview, I had spent about an hour defending a lot of questions about my stature and my capabilities to be able to, be a physician. I felt like maybe for the first time, despite my ability to work really hard, I might not achieve a goal that I wanted. Well, I did have one other interview, and that was at Johns Hopkins, as I mentioned. And on that interview, I didn't tell anyone that I was going up. I went up there, I met with a pediatrician who was my interviewer. And during that dialogue, he again asked me sort of the typical questions, what area of medicine I wanted to go into, and how about my extracurricular activities and, just grades and things. He never once asked me anything about my stature, to the point for a brief moment, I thought, does he know I'm a little person? Well, clearly he did. I was obviously sitting eye to eye with him. But I started to worry that maybe this was not going well in a different way. And maybe I needed to bring up the fact that I was a little person in case he was unsure and just afraid to ask. So I said, I would probably need a step stool and I would bring my own step stool to see patients. And then by this time, this interview, I had it all worked out in my head. I said, when I go around the campus, I have a scooter that I'll use for mobility and I can bungee cord my step stool to the scooter. So I always have it with me. And he just sort of, smiled and said, that makes sense. He said, if you were to come here, you just let us know what you need to be successful. And that was it. And I went on my way and I went home. Well, after those 2 interviews, I really did not think that I would be going to medical school, but I did get actually 2 invitations to join the class of 2000, both from University of Miami and Johns Hopkins School of Medicine. In the end, I ended up choosing Johns Hopkins because I felt like that was the one school that had the least amount of concern about my abilities to take care of patients and to be a physician. So this is the picture of our graduation, and you see I'm here in the middle. This was actually after the dean left. The initial picture was all very starchy and, hands by our side, and then Dean Miller left and we all had fun. So I share that story because it was really one of those early on experiences in my life where I really, had to sort of internalize my limitations as a person with a physical disability. And I wasn't sure if I was going to be able to achieve those goals of becoming a physician. I'm very happy to say that today I have, I'm practiced neonatology, and I still do a little bit, although less as I'm getting older and doing more of simulation. But I chose a profession where my stature really and truly was never much of a limitation. Neonatology, the great thing is my patients are never ever bigger than me. So with a step stool, it all works out. However, although today I'm very fortunate, I feel very thankful that I achieved my professional goals. I love practicing medicine. I love caring for patients. I love doing simulation and making a difference for patients in that way. But I still, like I'm sure many of you in the audience and, many of our colleagues, I still, have challenges related to diversity, equity, and inclusion. And I think all of us, as the more mindful we become of these issues, I think the more important they become for us to make better. So thinking of diversity for me, what is diversity? Diversity means that an organization essentially has a diverse team of people that's reflective of the population in which it exists and operates. Well, in going to medicine at the time that I was applying, it was actually absolutely okay and in the application that they could essentially, discriminate against or not accept anybody who has an inability to essentially perform the functions of medicine due to their physical or mental disability. Well, I understood that. The problem with that is twofold. Number one, it doesn't allow for the individual to speak to their disability, what they're capable of, and what they may be limited on. And number two, the challenge of those statements in those applications is that I, as or any physician, could essentially discriminate without having the big picture. And as you saw from my experience at the University of Miami, that trauma surgeon really felt that to go to medical school, you had to be capable of performing all aspects of medicine. Well, the downside of that is that you end up excluding so many, unique, talented, capable individuals because there's a perception that if you become a doctor, you have to be capable of doing any type of medicine, whether that's trauma surgery, pediatrics, genetics, psychology, psychiatry, or ophthalmology, right? And so that limits diversity. I like to think of that trauma surgeon as thinking, medical students needed to be pluripotent stem cells capable of becoming anything. But when you do that, you lose out on a great talent pool. So thinking about equity, equity is the concept that we are provided the resources that we need to work and perform at our fullest potential. Not the same, but in a similar way to anyone else. And so for me, equity is really about having my step stool around. My step stool is as important as a tool for me as a stethoscope is for anyone else. And, when I have recently, I'm going to share with you a very personal experience that I've had with a lack of equity in healthcare, because it still exists today. The story that I gave about my application process was probably something that I think was, related to the time, the era. It was 20 plus years ago. But even as recently as a couple of years ago, I had a challenge with equity that I never expected to have. And in this particular situation, I was applying for privileges at a community hospital in my area to do delivery room service. And, my chief of neonatology was very excited to have me do it. I was excited to do it because our children's hospital did not have delivery room services. And so you needed to go to one of the affiliate hospitals to keep up your skills. So I, went through the credentialing process. That all got done. And then, my division chief suggested dates for me to be on service. I said, that's great. Here we go. Let's go. Said, but oh, well, by the way, I just need to get, step stools placed in the hospital before I go take service there. Well, about 2 days later, I said to them, can you tell me what we should do to get that set up? I got an email back, from someone in my department saying, unfortunately, I would no longer be able to do delivery room service at this hospital because they would be unwilling and unable to purchase and or maintain step stools when there are other neonatologists who are capable of providing the same service. Wow. My heart sunk because that had never happened to me before, and I didn't expect that in today's day and age. Took me a couple of days to figure out how I was going to respond, but I knew I needed to respond. This stage in my career, I felt, regardless of whether or not I ever got to practice there, it was important for me to set this straight because there are folks that are applying to med school that are medical students and trainees that we are now, setting the stage for failure. Because if I was just an intern and that was where I was going to get my training, I would never have felt comfortable speaking up. So I knew I had to speak up. And I'm glad I did because in the end, they fixed it. I think, my own institution, said, we'll figure it out. And they purchased the step stools and I assume had to have a couple of conversations with their leadership. But I was willing to go to bat for it. But what to me, what was so sad is that had I not responded back with a, wow, I'm very surprised that, this is not possible. But if I had just said, okay, thank you so much, that would have just gone on without a second thought. So equity still is a problem today. And I think it's important for all of us to look for opportunities to help make the world more equitable for our patients and for our colleagues. Last but not least, inclusion. And I'm going to share with you from a personal reason why this is so important. Inclusion is really the idea of focusing on the needs of every individual and ensuring that the right conditions are in place for them to achieve their full potential and to feel valued. And that's what's most important, because by providing the support needed, you feel valued. The hardest part about that step stool example was not only was it an example of lack of equity, but it also made me feel not valued and, very disheartened in the, healthcare community that I love. So when we think about opportunities for inclusiveness, we can look for these opportunities in the way we design our systems of care, the way we design our processes, the way we design physical spaces. And I show you these examples here because the top one here, I was a patient and they had a bell that you ring when you survive cancer and you're done with chemotherapy. That bell was really, really high in the oncology unit. So they remounted it on a wooden platform just to lower it for me so that I could feel valued and included as a patient and be able to ring the bell like everybody else. A very minor thing, right? But it made a big difference. This is an example of my recent hospital room when I had my hip revision surgery. It's a good example of inclusion, but maybe not complete inclusion because they have these special chairs that are really high for hip replacement patients already set up in the room. And they had a walker set up in the room, which is great. Every room has it all ready to go. But, that's great to think about for all those hip replacement patients. But unfortunately, that was the opposite of what I needed. So the walker nor the chair worked for me, but it's nice to see that there's an effort going on. And then one of the things that I want to share in this next picture is once you feel supported and valued, then you can really be successful. And for many folks that thought that maybe my stature would be a problem, not only physically, but even socially from parents and in kids, I got asked I can't tell you how many times, how do kids react to you? Are they okay with you as their doctor? Are the parents okay with you as their doctor as a short statured individual? And to be quite honest, it's been an advantage for me. When I walk into the ER, like you see in this picture here with a kid who's crying, when I was a resident, most of the time, the kid who was crying and screaming and carrying on would completely shut up because I think they were just quite surprised to see a little doctor. So, and now that I intubate little babies, I'd like to think that even my smaller hands could be an advantage. So I share that because by having an inclusive workplace, and especially in healthcare, we can not only support people to reach their potential, but we can even benefit from some of the unique traits that persons with a disability bring to the table. And that's what's really exciting about DEI. So last but not least, I want to just share a little bit about microaggressions and implicit bias, because the goal of DEI is to really combat this, right? To help us avoid microaggressions and implicit bias that makes for either hostile work environments or just not inclusive work environments. And that happens to anyone and everyone at some point. I do believe that we've all been a recipient, but we may not even be aware of it. And for me, I can tell you there are many times when someone has said to me, "Did that bother you when so and so did that?" And I didn't even realize that what they were doing might have seemed like a microaggression. But now that we have a turn, we can start to talk about these situations. We can start to have conversations, and we can help all of us, including myself, become aware of our implicit biases so that we can start to address them, which is exciting. So why is DEI related to the disabled community, which is where I'm focusing from my own personal story, so valuable? Well, as I mentioned, there is great impact from those talented individuals that have a disability. And if we don't, look at the workforce with diversity and inclusion in mind, then we're going to exclude some really amazing people out there. It also is great to include persons with disabilities because it helps with the connections with our patient populations, right? I mean, we are the ones caring for patients with disabilities. So I can't imagine that it doesn't help in that relationship building, in that trust building with patients if we have something in common with them. And there are lots of studies looking at, companies in general worldwide, comparing non-disabled employees to persons with disabilities. And they found a lot of great benefits, equal or superior performance, loyalty, positive influence on the morale in the workplace. Oftentimes, persons with disabilities are more mature because of the life experiences we've been through, and they bring that to the table. And of course, as I mentioned, all of us are untapped resources, skills, and intellect, whether or not we have a disability. So when I think about, what is the solution? Well, there are many solutions to DEI. Simulation, I know, is not the only one, but I get excited about simulation as a tool for improving healthcare in general because I love it and I see the value. And I think we are just at the tip of the iceberg of really harnessing the value of simulation. So how can we use it as a tool to promote diversity, equity, and inclusion and mitigate implicit bias? Well, I'm going to share with you some of the literature first, and then I'll give you a couple of my thoughts on how we might do that. As I mentioned, I am not an expert by any means in the implementation of simulation for DEI. I think we all are still learning how to do this. But I think if we start having the conversation together, we're going to learn from each other and we're going to find great ways to help with sim. So, just to give some background, racial, ethnic, and other disparities, we all know this. We've been talking about this today. They're prominent in our communities, they're prominent in healthcare. And these are just some examples from the literature, related to Black and Latinx populations who may unfortunately receive not effective care related to cardiac medications, cardiac interventions, survival after cardiac arrest is lower, or even receive appropriate analgesics for pain. This is so sad to me. Racism and implicit bias can negatively impact birth outcomes and other health disparities, as you heard from Komal and other, faculty today. So how can we combat the actual delivery of healthcare? Well, I think we need to be aware of it first, and then we need to think of solutions. And, in addition to providing care, we even have hospital environments and workflows and systems that are, riddled with bias and actually lead to microaggressions that we may not even be thinking about. So the need is more than ever now for us to embed diversity, equity, and inclusion into our educational efforts, our patient safety efforts, and our clinical care efforts. And the idea of using simulation as part of the tools in your toolbox is growing, and there's growing publications on this. And so I think we can all think of innovative ways to do this. Those of us that are simulationistas, I think we get excited about being innovative. And so simulation, I think, is one of those tools that not only is innovative, but it just makes sense. It's a tool that, like others, we can help identify and improve those environmental biases and structures of power, like racism, classism, and ableism, and we can tackle those. Why do I think this? Well, number one, healthcare simulation is all about providing a psychologically safe environment for discussing difficult topics, and DEI conversations are difficult. And so the tenets of confidentiality and the basic assumption which many of us hold true from the Center for Medical Simulation about how we know that everyone that comes to simulation and is willing to unpack and explore difficult conversations related to their performance does so because they want to improve the good care that they already provide. We're all caring, competent, and intelligent when we come to the table. And so those tenets of what make good simulation happen also can help us to have these difficult conversations related to DEI. And then, of course, last but not least, simulation is immersive, it's experiential. And so it can allow us to really explore and reframe and change our behaviors related to unconscious bias, discrimination, and implicit bias. So there is a really powerful study. If you haven't read it yet, I encourage you to go read it by a good friend, an amazing colleague, Samreen Vora, and other colleagues in the Simulation and Healthcare Journal that came out in 2021. That looked at how we can use simulation to improve DEI. There are now over 20 publications that are looking at simulation as a tool to explore and improve implicit bias, and 10 that are even looking at virtual simulation to explore and improve implicit bias and racism. And so Samreen, in her article, talks about some of these, key studies and gives us sort of a framework for how we can do this well. And this is, part of that conceptual framework, which is really very similar, right, to the experiential learning Kolb cycle, and that you have a experience with simulation. Maybe it's disorienting, so that you can experience and start to uncover your biases. And then you have some self-reflective debriefing, that critical reflection. You learn and acquire skills, and then you practice with deliberate practice, and then you role model that new behaviors that you've learned. And so this is just an example of a framework about how we might apply it. Sakura et al. Also, as an educator, proposed a 6-step framework for integrating implicit bias recognition and management in health professions education in general. And so, as you see in this chart here, these were those 6 steps for, sort of having an implicit bias curriculum in healthcare professional schools. Well, I like to think that all of these 6 steps that Sakura put together really nicely correlate with simulation. And so if we think about this framework as one of the ways we can go about getting started with DEI simulations, we can follow each of these steps and see how the simulation correlate can help us make that happen with sim. And I won't go into details with that, but it's just, I think, a really nice way to think about our educational frameworks. Last but not least, as each of us are maybe thinking about opportunities to improve and enhance DEI and combat implicit bias in our environments, we could sort of have this, 6-step process for creating simulations. It's basically the same as any other simulation curriculum development process, only here we're changing our focus on, again, what is the needs assessment? What is the specific type of bias that we want to focus on in that particular educational simulation session or course? And then we can create those scenarios. We can develop a debriefing plan that targets questions related to, diversity, equity, and inclusion, and implicit bias. Of course, we need to have meaningful outcome measures to evaluate the impact. That's how we continue to get more support and grow this field. And then we want to, when we're actually implementing simulations, prepare our participants for those goals and really have a concerted effort on psychological safety. So that in that debriefing, we feel safe to talk about these difficult situations. So that would be sort of a framework that I like to just kind of overview when we're trying to create simulations that actually target improving diversity, equity, inclusion as the learning objective. But what about, any simulation for any learning objective? How can we develop simulations with a DEI lens? And here's some great keys that I've learned along the way as I was doing some research for my own work, trying to be more aware, knowledgeable, and deliberate in improving DEI with any simulation effort that I'm doing. Canigliera actually wrote this very nice article looking at where we have a lack of diversity in healthcare sims specifically. We know we have it in the lack of technology, right? And in the mannequins. So we definitely need more diversity in our mannequins. I don't need to, tell you all that. But there's also diversity in simulated patient names and even standardized patient names and how we use standardized patients. And there was definitely a lot of conversation earlier today with that. But here's some strategies to address those specific limitations that we have related to DEI that Vora, again, wrote in one of her articles, so that we can try to be better stewards of promoting, those implicit bias mitigation strategies in our simulation sessions. And so I definitely encourage all of us to review that when we're doing mannequin-based, standardized patient-based, virtual reality, or case-based simulation education and training. So let's also think about how do we prepare our facilitators, right? So Laura also created this really nice facilitator guide to help us in training and supporting our facilitators in these difficult conversations during DEI simulations. It's really important to prepare your instructors, I think, for these types of scenarios, and to even consider co-facilitation with an expert who has subject matter expertise in DEI to be a partner to you in that debriefing, if at all possible. Also, another strategy to help when it comes to facilitation is to consider authentic voices. So maybe including persons who have, either that background, that cultural background, or that disability that you're actually targeting for your simulation efforts to help in the design, the development, and the implementation and facilitation of those scenarios. That can really add, I think, to the power and the authenticity of that training experience. And again, as I mentioned, don't be afraid to use a guide. Create your own script if need be to help ensure that we can support our facilitators. Because many of us are not super experienced in this, but we may be tasked in our roles to helping with this. So again, thinking about evaluation, that's always very key. I love this EDI sim tool that came from Victoria Brazel and Eve Purdy, where they actually ask these questions so that all of us that like to do sim and debrief the debrief, after any scenario, you can sit down with your co-facilitators and say, did we do our best to really explore opportunities to incorporate EDI, they call it over there instead of DEI, into the simulation? And so this is just another tool in your toolbox as you're trying to enhance DEI in SIM. So as I get near the end, I want to share with you an idea that I don't think is well published yet. And in fact, I don't think there is really anything out there looking at this use or application of simulation. But how can we combine our interest in using simulation as a systems improvement tool, right? Systems engineering and integration. How can we use simulation as that tool, but not to necessarily only focus on patient safety, identifying patient safety threats, latent safety threats in our workflows, processes, and or clinical spaces based on how they're designed, but also can we use SIM to help uncover latent threats to diversity, equity, and inclusion? And I think, yes, we can. As a patient, all of my life, as a parent more recently of children who have been in the hospital, and as a provider in, delivering care, I have experienced opportunities that I just see them for improving DEI in our hospital design, in our workflows, in our processes of care, and they're just everywhere. So I think if we can start to think about simulation, not only as a tool to help us be more aware and decrease implicit bias, but also as a tool to help uncover these barriers to DEI in our systems, then we can really make healthcare much more equitable and inclusive for our patients and families. So can simulation do this? I believe it can. Healthcare simulation is a change agent for behavior change and for changing healthcare processes. So again, at the heart of healthcare simulation is this tenet of psychological safety, and that's key for having these brave conversations. And so the idea of using it to improve systems and spaces can really help equity and inclusion. So for those of you that may not be as familiar with simulation as a clinical system testing tool, or as a sort of, surveillance tool to uncover latent safety threats to patient safety, this has been well reported now in the literature for quite some time, as, really being a great surveillance tool where you can run a scenario in a new hospital setting, maybe like a new ER, or when you're about to roll out a new protocol like postpartum hemorrhage, and you can identify the flaws, the hazards, the latent safety threats that would have a negative impact on patient care had it been rolled out in real patients. Simulation provides you the opportunity to uncover some of those latent safety threats before they actually impact a real patient. And so now more than ever, I think we have this opportunity. And we can do this both pre and post construction. Imagine trying to do that. It would be really great to have an opportunity to understand how patients, especially those with special needs or conditions, would experience a newly constructed space, right? So targeting simulations of that patient experience, patient engagement, and patient care can really help to uncover those hazards to equity and inclusion and access. And using authentic voices is going to be part of the way we do that. When it comes to physical space considerations, I think it's just about asking questions when you're running these scenarios related to how the built environment impacts individuals, specifically individuals with disabilities or any other marginalized group. You could look at visual and auditory cues, floor plans, entries, exits, counter heights, access to supplies and technology, adequate number of handicap parking spaces. The gamut is huge. But by having actual participants who have authentic voices for those different marginalizations, then we can really get some feedback about how to break down those barriers. So what are some examples of conditions that we might look at? We would consider looking for, DEI issues related to persons with mobility impairment or visual impairment. So are the doors wide enough? Is there seating in long corridors for patients who may need to rest along their path, right? That's not something I think many of us would think about, even maybe myself. But then all of a sudden when I'm post-op and I'm walking around with my cane and I'm thinking, wow, there's no seat around here for miles. It gets, it starts to become tiring and exhausting for patients, and it sets the stage for lack of inclusion. Visual impairment as well, such as, is there the font size large enough on signage or documentation? Is there sufficient contrast between the toilet and the floor? Cognitive impairment as well is something to think about. Are the patterns on the flooring materials subtle enough so that patients can have good, wayfinding? Are there icons on signage to assist persons who cannot read? Behavioral conditions, right? Right now, with our current, need for improving mental health, we really need to be thinking about all of those persons that are walking through our doors. Have we provided an environment that allows them to interact with that environment in a positive way, reducing anxiety, obviously trying to prevent self-harm being key. So systems and processes can also be evaluated when it comes to simulation system testing. So we could look at our workflows for, potential bias, structural racism, lack of cultural competency, and or ableism. And again, the opportunities for evaluating different processes of care, as you see here, are endless. So what are some key considerations that we might want to think about? I'll just kind of go quickly through these as we wrap up. But, again, I mentioned this already. Authentic voices, I think, is number one when we're using simulation as a tool to identify threats to DEI in our workflows and hospital environments. We want to use authentic voices for patients so that we can really partner with our patients and families at getting at those barriers. We can also create debriefs that focus on questions related to latent threats to EDI or DEI. I use those terms interchangeably. I actually like EDI, which I know is common in Australia and overseas because equity to me is so important. I like putting it first, but in general, we can create those debriefs with open-ended and reflective questions that engage our patients and families who may have participated in that sim to get feedback on known areas of concern. We can train our facilitators again on how to have these debriefings and discussions. And then what are some of the categories of findings, right? So we have to be able to report out and then mitigate the issues when we find them. And I think we can break down those categories in the same categories we might do for a patient safety focused system test, resource issues, system issues, facility design, and performance gaps. And these are just some questions that you might ask related to each of those categories to get at some of those specific categories for DEI threats. And last but not least, when we're trying to utilize simulation to improve hospital systems, processes, or design of spaces, we can take that six-step approach, just like we did with making simulations for education purposes. But here, I think the big difference is we really want to include in the needs assessment and the creation of scenarios and in the implementation of simulations, authentic voices. So engaging those stakeholders that have the same challenges we do. So in the end, I hope sharing my personal story and my passion for simulation as a tool for improving DEI has inspired you to get out there and think of ways that you can combat implicit bias, that you can help improve DEI in your work setting and in your just personal setting. It's a commitment that I think we all want, and I think over time we're going to see more and more expected. And I think the more we talk about it, the easier it will be to combat it, and the better off our communities will be with better outcomes for our patients. Most importantly, in a much more supportive and inclusive community. And with that, I thank you.
Thank you so much. Just want to put out there, I love the fact that we really brought in the notion of using, a quality lens to go ahead and address a lot of these issues, and then partnering with the communities that we're trying to, work with and to improve our care, improve those health outcomes. We have only a couple minutes left, and what I'm going to do is I'm going to invite Dr. Trish Youssef and Alex Lee up to go ahead and ask one question to Kelly, Jen, if Komal's around, and Dana to see how you guys all answer that question. So I'm going to invite you guys up.
I'm trying to, just as a quick note, I'm trying to stop sharing and I'm having a little trouble figuring that out. If you have any guidance, I would definitely. Thank you.
Thank you, Michael, and thank you to the panelists today for such a wonderful topics and such insight into equity, diversity, and inclusion. We have a question for all our panel members today.
And we only have time for maybe one question, so we decided to ask this question. Should cultural competence and bias training be used with simulation as a competency for trainees and practicing clinicians?
I can certainly start that conversation. I think the short answer is yes, but it's not enough. That I think if we limit ourselves to thinking about it as just a one-off competency, that we're not going to set ourselves up for success. So how can we continuously use it as a practice? I think Kelly spoke a great deal about this too, and thinking about how can we make sure this is an ongoing opportunity and not just like a one and done competency. And I would probably encourage us to look at how much time is spent in training programs on issues related to diversity, equity, inclusion, and belonging.
Would anyone else like to respond?
No, I think I agree with what Dana said. I kind of the idea that this can be a competency, like a competency can be achieved. And there's no way with our diverse populations that we can have just a one and done. And it treats it as if it's a goal instead of a journey. And so there are parts of this, I think it's yes and. We also really have to stop thinking just about implicit bias when so much of the care environment is explicit on our forms when we ask about parents, right, in certain relationships. You know, I heard about capital improvements, which is something I need to think more about, like how people can physically move through the space. And so I'm just aware, like when we call something a core competency, it's like a checkbox, and once we achieve it, we don't revisit it. And so there are pitfalls to that approach, and I think we have to be more dynamic in our solutions.
Yeah, I just wanted to say I agree with both of the other panelists, and just to echo that I think it's about a state of mind, and it's about just being more aware, more open, more sensitive, more thoughtful, and that simulation can help with because it's going to make us more reflective and self-aware, but it's not necessarily something that we can sort of check a box and say, oh, they are competent and this person doesn't have any implicit bias. I mean, I think that's almost an unrealistic and impossible goal, but it's more about the more exposure we get to training and conversations related to DEI, then I think we will be well on our way towards getting to a much better place. Because again, when I think about just within skeletal dysplasias, our physical needs are so different and different from other folks in other disabled communities. So it's going to be hard to ever, sort of tackle everybody's needs for perfect inclusivity. But if we're talking about it and we're having the conversations and we're actually just, again, talking to individuals and asking them what their needs are, then I think the training can help us have those conversations and make our environments and our communities more diverse, equitable, and inclusive.
Thank you so much. And now I'd like to invite Dr. Megadichian for the closing remarks for the symposium today.
Thank you so much, everybody. Just an awesome and inspiring day, and learned so much, and have so many new ideas to kind of move us forward to use simulation as a means of going ahead and attacking diversity, equity, and inclusion. I wanted to go ahead and say thank you to all of our amazing contributors today, to Jen, to Kelly, to Komal, to Nicola, to Dana, to Michelle, Ivy, the Maternal Mortality Reduction Program, just everybody that went ahead and contributed, Ariel, just an incredible opportunity for us to learn and grow together. I also wanted to go ahead and thank Dr. Allen for supporting this event. It really wouldn't be happening without the support of central office and helping us move us forward. All of the speakers' work here is inspiring, and I hope that we have helped set people on a trajectory to rewrite our future, use what we know to build bridges and call people into this conversation to make healthcare equity a thing of the past, or inequity a thing of the past, and really think about the notion of health justice and really going ahead and changing the way that we're approaching things. Quality as well as education needs to be used as a weapon to go ahead and fight this war, to make a difference. And I think that all the people who have been on this panel is doing that, and I'm excited that we get to join in that fight. So thank you all and have a wonderful rest of your day. I look forward to what we have coming in the future. Thank you.